siendo algunos de los primeros afectados la lengua, a pesar de no presentar síntomas precozmente, o los músculos subescapulares. Entre los primeros afectados también se distinguen algunos músculos de los muslos, tales como los aductores, isquiotibiales y cuádriceps, así como los músculos de la pelvis, los paraespinales o los oblicuos abdominales. Para una correcta evaluación de la debilidad muscular es necesario realizar una exploración muscular en la que el músculo explorado esté en posición adecuada y evitando el efecto de la gravedad. Realizar una exploración funcional como la maniobra de Gowers. Evaluar cómo el paciente salta, sube escaleras o se mantiene a la pata coja, entre otras. Y anotarlo en su historial para poder llevar a cabo un seguimiento. Además, hay otras técnicas que se pueden emplear, como la resonancia magnética, que resulta de gran utilidad en el diagnóstico diferencial, la biopsia muscular, que indica patología cuando se observan vacuolas cargadas de material Pas positivo y una fosfatasa ácida alterada, pero que puede ser normal en un 30% de los casos, y el estudio en gota de sangre seca de una alta sensibilidad. No obstante, siempre requerirá de un estudio de confirmación genética posterior. La insuficiencia respiratoria temprana es una manifestación típica de la enfermedad de Pompe de inicio tardío y la principal causa de morbimortalidad. En algunos pacientes, esta es la primera manifestación de la enfermedad y un tercio requieren ventilación mecánica no invasiva antes de la pérdida de la marcha. En un principio solo se requiere ventilación mecánica nocturna, llegando a necesitarse las 24 horas según avanza la enfermedad. Estas manifestaciones respiratorias afectan a la musculatura abdominal, orofaríngea, intercostal, diafragmática. La debilidad en la musculatura expiratoria se traduce en tos ineficaz e infecciones respiratorias a repetición. Si hay debilidad orofaríngea, puede haber eventos obstructivos que provocan episodios de desaturación de oxígeno.
Vale, sí, por no andar cambiando. Buenos días, bienvenido.
Good morning, welcome, and thank you once more here to participate in this fourth edition of the Pompe disease. This fourth edition has an incomparable framework, which is San Sebastian, to keep on learning, exchanging experiences, and this Congress insists on our wish, which is to make our Pompe disease well known, and having studied this, and also to get to a cure. And during this day, we met together in the Fourth Congress of Pompe, the patients, families, researchers. And we are here, all those who are involved in the study, investigation, and research to become a reality. From the visibility and the study depends our quality of life, make our life easier, their life easier, and having the same approach in all spheres, educational, professional, leisure. Investigation is key to find a cure. During this year, we have had a very nice news. We have approved the first health two first health treatments that have been approved. So on top of the replacement enzymatic therapy, we have the fibaglucoside, who is a combination with the other ones. It is a replacement therapy to improve the absorption and the elimination of the glucogen in the tissues. These therapies are there to improve the respiratory capacity and slow down the degeneration of muscle, giving a better quality of life to the patients. These new medications are giving us new hopes, and I hope they will keep on progressing to have a whole and comprehensive treatment for our patients. We held this Congress full of hope with this news, but also with the hope of carrying on studying and investigating. This program has been possible thanks to the presence of experts, researchers, and doctors. Without their contribution, this Congress would have no sense at all. So we have been working hard to organize this Congress, and I would like to thank Sanofi, Amicus, Astellas, and collaborators as Bio-Gipuzkoa, FEDER, and the ASEM Federation, thanks to our sponsor. Without them, it wouldn't be possible. With the Fourth Congress, we are reinforcing the history of this small association that exists for those patients affected by the Pompe disease. Many thanks to you all. And now I give the floor to Itziar Vergara, who is at the head of the Research Institute. Itziar Vergara uses the floor. Good morning. On behalf of all the workers of this institute, I'm very happy to host this Congress. It is a pleasure, and having here hosting this Congress at home, an activity such as this one is always nice to host in our center, but most particularly because here in this house, we defend one of our major values of this center. We have the pleasure to manage, because these days we are underlying the importance of the understanding and why disease is happening, to use this knowledge in order to improve the diagnosis and to offer treatments and therapies to those who are concerned by this disease. But we do that in a collaborative way. We gather all the stakeholders, the researchers, the industry, but most of all the patients and their relatives. I have the impression that you make a great effort to inform the families and the patients in order to better approach this disease. And also, you communicate to society. You are keen on disseminating these approaches. These values are the ones we defend. So this event today is a very good example of what we do. We want to work hand in hand with patients. So thank you on behalf of our institutes for having chosen us as the headquarters of the Fourth Congress. I will be very happy to stay in the room with you and share all this knowledge. Thank you very much. Thank you for being here. I declare open this Fourth Congress of the disease Pompe, and we start with the transition program from adolescence to adulthood by the Dr. Itxaso Marti.
Gracias una vez más por su presencia.
Thank you once more for being here. I'm receiving myself a transition program from adolescence to adulthood. Good morning. We start this Congress with this presentation, transition program from adolescence to adulthood. You might know that these studies are there to ensure not only a health approach, but also a psychological and a mental approach. This transition becomes a quite relevant period because we have many factors that are involved in this disease, but also educational, sexual, social. That's why it is of great help to minimize this situation. In order to approach this, we have among us the physician Itxaso Martin, who is going to present this transition program from adolescence to adulthood.
Hola, bueno, buenos días, egunon.
Good morning. I'm Itziar Martin. I'm a neuropediatrician at the hospital of San Sebastian, and I'm at the head of the multidisciplinary consultation. And one of our major interest when coordinating ourselves with the adult unit is to work on these adolescents, and would like also, of course, to thank you for inviting me. And I'm sure that I'm going to learn a lot throughout this morning. Why it is so important to talk about transition? The transition is a difficult moment for teenagers. We know that it is in general a difficult moment for all these teenagers with, above all, with chronic and complex diseases. There's a sense of rebellion that are going against institutions and their parents and everything. So we are more and more in this kind of situation because the kids with severe conditions are having a greater lifespan,
Llegan en una buena situación a la
are reaching, or they are in good health to adolescence, and we have to care about this transition to adulthood. It is a very complex situation. Sometimes they do not want to go to the doctor or a physician, and if these reference, which has been that doctor, this primary care doctor, and they have to go to another service, it is even more difficult to lose the follow-up. And when we have carried out surveys, we have seen that the part of the patients are going to lose a contact with the primary care attention. So therefore, this cannot be left to improvisation. We have to act in an orderly manner, and we work together, the Spanish Neurology Institution and our department. So we are writing down a document, a report, in order to do that in a better way. What is a transition? It is not a moment. It is a process that takes time. The span is from 2 to 4 years. It is when we dedicate ourselves to families, the pediatricians, we talk with the families, and we are not so much focused on the patient. And so we go from a family-centered approach to a patient-centered approach. The patient is going to be the protagonist of this story. So we understand as transfer this moment when we go from the pediatrician consultations to the adult consultation. It is going to be a specific period from 2 to 4 years. What do we do? Up to now, we have cared about a transition model focused on the disease. The cardiologist, from the pediatrician to the pneumologist, and we all work as if we were in silos. And if we just cut down the individual into pieces, we are changing this focus, and we are doing that on a multidisciplinary approach. A team of physicians that are caring about the health of a patient, a young patient, is going to be transferred. It is going to, the family is going to transfer the child to the multidisciplinary teams. It is a process, and we have several stages. The first one is a stage of preparation. The neuropediatrician has to plan together with the family and with the teenager how is going to be carried out this transition. First of all, we have to be sure that it is the moment. Administrations are going to tell us that going from pediatrics to the adulthood is done when they are 14 years old, and for the chronic diseases, it goes from the 14 to 18 years old, and we, the physicians, we are going to decide when it is the best moment. In teenagers, they might have to be they have to undergo a surgery for scoliosis, or they have to have a more invasive treatment, and in those years, we cannot carry on with the transition to adulthood. So we have to be aware when is the best moment, when the adolescent is going to agree with all this process. During this process, we also have to empower the patient. We have to, the teenager has to be responsible, has to care about his situation, about his medications. He has to manage the visits to the physician. So promoting self-care is a key element. The professional or physician is an expert in disease, but the teenager knows what is its life and is also aware of its situation. So we cannot treat the teenagers without caring about important things. If he has to follow a treatment, if he has to come to the consultation or to the doctor's office, he has to choose the appointments to have a good follow-up of the treatment. I've got an exam. I prefer to come later on in summer, for example. So we have to care about all these details. As has been mentioned previously, not only future education work, but also leisure time, free time. And adolescence is when we separate from our families. We want to be with our peers, our friends. So those kids have many issues in this respect. We have to support them in all this process. We have to listen to them, and we have to find solutions, and it is a part of our work. So emotional aspects have to be bear in mind. How can we assess the competence? We have to make sure they're following medication, the appointments, the follow-up. We have to communicate. The teenager has to communicate with its nurses and physicians, with the ones he has to get in touch when he has a concern. He has also to be at the center of the decision-making processes. We have to turn to the patient and not only to the family. We also have to give opportunity to talk alone without the parents. This teenager has to have its own time to express himself freely. Ask him about his health, work, social goals, and explain with detail what is going to be the transition, how it's going to be planned, and when the change of doctor will take place, and how it's going to be done after. What what does confidentiality mean? What is consent? What is this that means and autonomy? And we mustn't close the door until he feels autonomous and independent within the new team. And little by little, they are going to gain autonomy. This is the transfer stage. Depending upon the institutions, it goes from 14 to 16 years. What can we do? We are going to plan 2 consultations. The first one in neuropediatricians, where the neurologist, adult neurologist, is going to attend. He's going to know the new doctor, physicians, and then there's a second consultation a few months later with the neuropediatrician that is going to be there to say goodbye. The neuropediatrician is going to coordinate the other specialties. Each specialty is going to care about the transfer to the different specialties and pneumologists, cardiologists, nutritionists. And besides these consultations where we get to know the families and the patients are going to get to know the new doctors. Apart from the physicians, there is a medical meeting where they communicate and they address all the important issues of the case. It is a quite difficult moment because we have a lot of information, but these informations are not always easy to find in the file. So we have to have a good document, the disease, the genetics, when it was done, and the other, how the disease started, the onset of the diseases, the problems. What are the medications that have been used? What is the situation, the current situation, the scales, the values, clinical continuity in order to address all the medical history. So this report, this document has to be a consensus with the family, because sometimes these histories are so dense, it is very difficult. And the following phase is integration. The integration when we start the follow-up as adulthood, in the adulthood. And so we do not want to cut off the communication with pediatricians until sometimes has elapsed when the onset of the confidence. And at the beginning, the adult consultation, the frequency has to be, they have to be more often. So we have to have this confidence. So the patient has had to apprehend his own situation. We also have to inform on how to act in each case. The communications have to be clear. They are clear in the pediatrician unit, but when they go to another unit, they have to know who is the contact person in case of an emergency. If he has to call to his primary care doctor, everything has to be clear. So with this feeling that it is the transition, the families are going to say, where are we heading to? We are on the verge of a cliff. And they have the feeling that they want to be as adults. They have to do that in a way that they mustn't feel alone. They will be cared about the people. They have to know what are the interests. And that's all. Thank you very much.
¿Alguien quiere hacer alguna pregunta?
Anybody wants to ask a question? Hello, with the microphone, please.
Bueno, ya nos conocemos.
I met you yesterday. I would like to say that you have a fantastic target audience here. Maybe if I have met you 2 years ago, I would have wanted to hear about your ideal world. it should be like you described it. The problem is it's not real. In the case of Ivan, it's 5 different specialists. The first person who helped us was the physiotherapist. It was a mistake because we were pushed towards treatment when he was in the 3rd degree of growth of his body. So during these 2 years, we've been through 3 physicians, different doctors, and I have to ask for the various review visits for my kid, because when I was in the maternal hospital, I had a visit every 6 months. But when he got into the adult section, I had to ask for 3 different visits, and I was sent to the healthcare center. Then they sent us to the specialist. It was chaotic. It's still chaotic. After 3 physicians, the last doctor said, yes, he needs to go to the scoliosis department. But it's been worse and worse for my kid. And I felt that was a real transition, and we need help for the transition. And we were not really accompanied. Now with the neurologist, it's different. With the gastroenterologist, I think there is contact. And Ivan, if he wanted to be there up to 20 years old, it's like a family. So we were in the maternal hospital, we were welcomed, and now it's a hostile world. It's a saturated health system. So when you say that you're going to meet to know my kid's case and that the neuropediatrician and the neurologist are going to attend, I think this is not the case in our region. Well, what I just described, that it's kind of a guide, as it should be. And of course, as you say, would be the ideal procedure. But then every situation and every hospital is different, and it's very difficult to implement all this. Maybe we make mistakes. We continue to make mistakes on many situations. I understand that. But it doesn't mean that we don't need to fight towards the ideal situation. Maybe in 2 years' time, I will tell you something different. But your transition you mentioned from 2 to 4 years of age is disorganized. It wasn't organized for us because in the maternal hospital, we were very fantastically treated. It was fantastic. They were so kind, they were so professional, and now during the transition we get to the other hospital and it's chaotic. 3 doctors in 2 years. I know that medical histories are there, but it's very complex. In 2 years I had to go to 3 different doctors. I'm talking about rehabilitation. I'm not just talking about neurology. Yes, it's the case for us too. At the beginning, we are with the babies. We know the doctors. We know patients. We know families. We have a very close and warm contact with families. And then people are afraid of going to the adult section. But the adolescents themselves, I think it's good for them to change their mindset, their perspective changes. Sometimes when they came to the office, I have lots of flowers and drawings and things for little kids. A guy of 16 years of age, he doesn't like the kids' drawings and the little things for babies. He or she is an adult, and we need to treat them as adults. So this transition is difficult, and I suppose that we have to organize us better for adolescents. It's my experience, but then you know each other. You go to congresses, you meet, and you see where the problems might arise, and you adapt to reality. I understand what you mean. He will be in very good hands, and he'll adapt to the new medical team. But for the moment, this transition for him is very difficult. One of the reasons why we wanted to have this guide is to publish this guide so that physicians themselves can ask for resources and not get organized. They need these resources to have a better treatment in the future. Thank you for this transition. Any more questions? I would like to confirm what Lola said. I'm the mom of 2 teenagers. And Lola was right. In theory, it's fantastic what you say. But when we got to the adult service, it was so different. It was chaotic. So please, convey the message. At the beginning, it's like their second home in the pediatric section. They feel at ease, they feel at home. But then they change day hospital. They go to different offices. They've been together with an 80-year-old person. They are completely lost when changing, when transitioning to the adult section. So we need to adapt that. I'm talking about the look forward. I'm talking about the future. That's why we should behave and how we should be organized in the future. That's what we're fighting for. This is theory, as I told you. And we have to realize that we make mistakes. It's not just the specific case of Lola in Malaga. It's the general situation in Spain. As Lola said, you know each other, you go to congresses, and adolescents are a bit lost. They are living in a limbo. I don't know if anybody else would like to take the microphone and ask questions. Otherwise, we say thank you to the doctor. Thank you very much.
Para la siguiente
For the next talk, I suppose you may need the headphones for the simultaneous translation. You will find them outside in the boxes.
Sí, sí. Ahora sí. Ya. Experiencia en Pompe infantil.
Experiences in infantile Pompe. Let's continue. Let's talk about the present and future of Pompe disease with infants. In the Patients Association, we insist on this because it's very important about infantile Pompe disease. We have to have early diagnosis for these patients to improve survival and the quality of life of our patients. What is the situation now of infantile Pompe? What are the lines of action now? What is the research activity in this area? Dr. Hannerieke van der Hout will present this talk. She works in the Centrum voor Lysosomal and Metabole Ziekten. She was invited in Pompe, infantile Pompe, on previous occasions because of her long experience. You have the floor.
Okay, well, hello. It's a pleasure and an honor to be here. Should be a bit away from the microphone. I'm Hannerieke van der Hout, and I'm a child neurologist in the Center for Lysosomal and Metabolic Diseases in Rotterdam. And I've been working with the team from Arnold Reuser and Hans van der Ploeg since 1999. And it's a great honor to be invited here. And a pleasure, because I think in rare diseases, it is important to go over the role, because if we want to get insight in these diseases, we have to collaborate together. Otherwise, we will not learn to know the new future of these diseases. So, let's see how this works. It works. So, the journey into the unknown of Pompe disease started in 1999. And it was very much like the explorers, going on a journey with no way of knowing where you were going to end up, to terra incognita and mare incognito. So 25 years later, where are we and what have we learned? So let's just visit the baseline for classic infantile Pompe disease. So that is the most severe form of the disease in which there is no residual enzyme activity and severe accumulation of glycogen. We looked at 20 Dutch patients and 119 cases from the literature, and to learn to know the cause of the disease when it was untreated, the natural cause. And we found that these children, when they were not treated, presented within the 3rd to 4th month of life and would develop a progressive hypotony, making it impossible for them to ever achieve motor milestones like standing or walking. The hypotony would be progressive, and they would also develop a progressive severe hypertrophic cardiomyopathy. And the combination of the heart involved and the respiratory muscles being very weak then would end up in cardiorespiratory failure and death before the first year of age, so in a mean age of 6 to 8 months. So that's the baseline. And then in 1999, the first patients, both in Rotterdam and in the US at Duke University, were treated. And this ended up in 2004 with the first surviving children able to walk. Research continued, and finally, recombinant alpha-glucosidase, myosin, was registered at a dose of 20 mg per kg every 2 weeks. When we now look at the cohorts which have been published in Germany, France, Italy, and the Netherlands, we see that these cohorts differ a little bit. At the upper row, you see Germany, and they studied their surviving patients. And the other groups, France, Italy, and the Netherlands, they studied the patients that they treated on the whole. Looking at the rates of survival, you see that it varies in between 54 and almost 100%, with ventilator-free survival, varying from 30% to 54%. And this is very good. But when we then look at the percentage of children that is able to walk, that's lower. It's in between 25 and 75%. And persistent walkers is even a little bit lower. So in between 21% and 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. 36%. Importantly, when we look at the dose of the patients treated, we already see that quite some patients in these cohorts were treated with doses higher than the originally registered dose. So that's where our lessons learned start. And I will talk about dose and dose frequency. I will talk about an early start of treatment. And I will also talk about monitoring and management of high antibodies in this classic infantile most severe population. So dose and dose frequency. As we found out that the dose that were actually used in practice for classic infantile patients were higher than the registered dose, we decided together with the European Pompe Consortium, the APOC, to study the effect on survival and walking ability of these different doses. And we looked at the cohorts coming from Germany, France, Italy, and the Netherlands. And we looked both at the constant dose regimens and on the whole group, because we saw that a lot of children changed their dose over time. So looking at a population of 116 patients, we found that in the upper right corner, when you looked at a constant dose regimen, that those children with the red line, with a constant high dose of 40 mg per kg every week, had a better survival than the patients who had lower doses. And when we then looked at the whole group, and those are the two graphs below, looking at their initial enzyme replacement therapy dose on the left side, and their final dose on the right side, the graph G, you also see that those patients with a high dose had a better survival. So dose matters, and a high dose, myozyme 40 mg per kg per week, is important. So what about early start? In Taiwan, newborn screening was introduced quite early, very early when compared to other countries in the world, in 2006. And when they compared those children found with newborn screening, so very early, the red graph, and they compared them to their other patients who were found a little bit later, the blue graph, they found out that survival was better if children were diagnosed very early. So an early diagnosis, either by newborn screening or by a very high level of suspicion, is important. So what about management of anti-drug antibodies? Anti-drug antibodies, what is that? Well, if your body gets a foreign protein, the immune system will start to make antibodies to that. When an enzyme replacement therapy can also be recognized as a foreign protein. So on the left side, within the red circle, you see the therapeutic protein coming in and being recognized to a particular cell of the immune system. That cell will then present the therapeutic protein, the foreign protein, to the rest of the immune system, and that will start a cascade of action in between the white blood cells, ending up in the production of antibodies. And late onset patients will have some enzyme activity. Therefore, the enzyme is present in the body. This is called CRIM positive, and the protein is known to the body. Whereas classic infantile patients do have residual, almost no residual enzyme activity, and they may either have some enzyme present which is not working. This is called CRIM positive, so the protein again is known, but they can also have no enzyme production. Therefore, they are called CRIM negative, and the protein is unknown to the body. As when the protein is known, there is a lower chance of developing anti-drug antibodies. So that means that late onset patients have less frequent antidrug antibodies than classic infantile patients. And CRIM-positive classic infantile patients have a lower chance of making antidrug antibodies than CRIM-negative patients have. So what can happen? Well, this little girl did develop antibodies. You see her on the left side at age 2, then at 4, and then at 6 years. And as you can see, she gets weakness around the hip girdle. And eventually, this ended up in becoming wheelchair dependent. And this is not the only reason for which children can get wheelchair dependent, but it's one of them. And you can treat antidrug antibodies. It's very complex, and it is very, very challenging, but it is possible. You can either try to prevent formation of antibodies. That means that you have to start immune tolerance induction before start of enzyme replacement therapy, and that is treatment with rituximab, methotrexate, intravenous immunoglobulins. Or you can try to treat high antidrug antibodies. And you can do that by adding bortezomib to the combination with rituximab, methotrexate, and immunoglobulins. And when done properly, it is still challenging, and you have to continue treatment for a very long time. But then this might be a way of getting the antidrug antibody titer down, or to prevent the formation of antidrug antibodies. Antidrug antibodies can also induce infusion-associated reaction, and you may know these. These also occur more often in classic infantile patients than in late onset patients, and that means that during the infusion you can develop a rash. It can be itchy, you can start to feel bad, you can feel like getting a lack of air, you can get a saturation drop, fever, shivers. What you need to do in a case like this is stop the infusion. When you stop the infusion-associated reaction will also wane away. But you have to be able to manage the infusion-associated reaction in all the infusions thereafter. Ways of doing that is either to start pre-medication and to adjust the rate. And generally what we do in our hospital, and it's different around the world, is that we use lower rates at the start of the infusion and then gradually ramp up the infusion rate to a high rate at the end. And we really believe that a high rate at the end is very important to get the enzyme to pass the liver and the spleen and actually reach the muscle. So, with all these lessons learned, the effect of enzyme replacement therapy and the outcome of therapy, it improved over time. We changed the lethal disease to a disease in which children got the chance to survive and a chance to walk. And the oldest patients are now in their 20s. So, how is the long-term follow-up? Well, primarily, the disease is not only a muscle disease, and as you pointed out, a lot of doctors are involved in the disease, and a lot of organs show problems. Children may develop weak faces, have problems swallowing, can have repetitive airway infections, can have hearing problems, need glasses often, have osteopenia, so very fragile bones, and can develop a scoliosis. But I will specifically look into the results of the heart, walking ability, and brain and cognition. So, the heart. The effects on the heart are very rapid and very good. Within the first year, the hypertrophic cardiomyopathy normalized. Effects on the enzyme on the heart remain very good. So the heart keeps being normal. However, when we look at the EKG, so the heart movie, as we call it in the Netherlands, we see some signs that children might be at a risk of developing rhythm problems of the heart. So that's something that you have to follow up over time. What about walking? Well, again, the cohort of Germany, France, Italy, and the Netherlands. And as you can see in the left side, children learn to walk, and a higher percentage of children learns to walk when the dose is higher. But in the end, we want to keep everybody walking persistently. When we now look at the walking of those children who have learned to walk, on the right side, you see that over time, some of the children lose the ability to walk. So why does that happen? Oh, this is a little bit of a difficult movie, I see. I'm sorry about that. But this is a child, and you see her walking pattern over time. And if you look at the pattern, you see already here that she is not landing on her heel like you should do when you're walking. First the heel, then the rest. But she starts to land on her toes. So on her feet. And that's abnormal. And it's also abnormal for the pattern of muscle weakness, which you see in Pompe disease. It's a limb girdle weakness. And now we see that distal muscles also get involved. So we wanted to check that in all our patients, and we did in these 16 patients, and these are difficult graphs, so I'll take you through that. When it is green, on the left side you see the lower extremities, on the right side you see the upper extremities. And each patient has 2 bars, so each 2 bars is 1 patient. The upper bar is the proximal muscles, the lower bar every time is the distal muscles. Green is good, normal function. Yellow and orange are somewhat impaired muscle function. Red is loss of muscle function. So what we learned is that children learn to walk at the age of 1.4 years, which is not too bad in the Netherlands because Dutch children walk in between the first year and 18 months. But children did develop distal muscle weakness. It occurred early, even before proximal muscle weakness. They had frequent weakness of the feet and less frequent weakness of the hands. And distal muscle weakness in the feet was often profound, and children would need splints and foot ortheses. And over the world, it has been studied what is the cause of this distal muscle weakness. And there are some centers that have found signs that it's mainly coming from the muscles, and other centers who have also found indication that it originate in the nerves. So we don't know exactly what is causing this. So what about the brain? Because when we started treatment in 1999, we already knew that glycogen also accumulated in the brain, although to a very low amount. And we knew that enzyme replacement therapy cannot pass the blood-brain barrier because the brain is very protected. And this is good because if we get an airway infection, it doesn't go immediately to the brain. It has to go to considerable trouble to get into the brain. For a disease, that is good. For a treatment, not so much. It's a challenge. So we followed up the outcome in the brain to see how the children did when they survived on treatment with the brain not being treated. And what we found, and these are MRIs of 1 patient. And on the left side, you see an MRI of a healthy person. And as you can see, it is the brain. It is a section like this of the brain. And the light gray and the convexity, the outside of the brain, is called the gray matter. And the dark central part around those white bananas, that is the white matter. On the right side, the MRIs of the patient, and you can see that at the arrows, the white matter, which should be dark, now becomes lighter. And this is called white matter abnormalities. And when we studied this in all our patients and scored it with the Pompe brain score, we saw that the amount of white matter that became abnormal increased over time. And when we then looked with MRS glycogen to the brain, we found abnormalities. On the left side you see a healthy person, on the right side you see a person with a classic infantile Pompe patient, and we found that they had an abnormality on the scans which was clearly abnormal. Here the normal control, and here the classic infantile patient, and there was a significant difference between the both. And the abnormality we found was exactly the same as what we found when we put pure glycogen in the MRS. So we were able to show glycogen. So there are white matter abnormalities. They do progress over time, and they seem to be at least related to glycogen accumulation. So imaging is one thing, but what really matters is how classic infantile patients are in their daily life. And they have good lives. They have important lives. They communicate. They go to schools. They learn to play. They play games. We wanted to know exactly, although they were doing all that, how their cognition was. Therefore, we performed neuropsychological tests over time. And when we first look at the graph on the right lower corner, called processing speed, we see that their processing speed, their speed of thinking, gradually declines over time. In itself, that is not a very bad thing, because it only means that they might need a little bit more time, or they cannot maybe learn in a group of 30 children at school, but they can still learn in a smaller group, because in a smaller group they can get more individual attention. But as this is happening over time, this is important, because it shows that there is an effect of what we see on imaging, and that over time it progresses, and that we need to get into the brain with innovative treatments. We did find a lot of variation. So some children developed totally normal, whereas others had some slight cognitive problems, and yet others were had more problems and even could develop epilepsy. So there's a wide variation. So what we have learned is that innovative treatments need to include the brain, and there's good news as well, because lentiviral gene therapy, modified stem cell transplantation may be a way of both treating Pompe disease with gene therapy and also getting to the brain. And what is this? Well, you have a patient. From the patient, you take its own blood-forming cells, stem cells. Those stem cells you modify with lentiviral gene therapy. At the same time, the patient gets therapy, and then you make space in the bone marrow. And this is severe because it's like a stem cell transplantation, so it's like chemotherapy. When you then have empty bone marrow in the patient and the modified stem cells of the patient with gene therapy, you then give these stem cells back to the patient. They will then go to the bone marrow, start to produce white blood cells with normal enzyme activity, which then will be secreted in the blood and which will then go to the muscles. Those stem cells, when the patient is treated with a certain chemotherapeutic agent, busulfan, are also able to cross the blood-brain barrier and then will home in the brain and produce enzyme replacement therapy at site there. So all in all, I think since 1999, 25 years ago, we made a giant leap forwards. However, there is still remaining unmet medical need. There are still problems. Therefore, new innovative treatments are needed, and these need to include the brain as a target. Well, I would never been able to do this by myself. That's very obviously. So we work in a very big group. Within the middle, Professor van der Ploeg in the grey jacket, and with the white, how do you call it? Clothes. That's Pim van der Ploeg, Pim Pijnappel. And all together, we have been able to do this job. So this is not only my work, it's of a whole team. On the left side, you see one of our students, Marta Faraguna. She's from Italy. And we are always very happy to have students from all over the world visiting our center and just working towards the same goal. So if there are any other questions, I would be happy to attain that. Thank you very much.
Las preguntas las vamos a dejar para después.
We're going to deal with the questions afterwards. Pompe Infantil. Now we have the professor Hannerieke will also be a part of the panel discussion. So this panel session was going to be chaired by Javier de las Heras from the Cruces Hospital, but for health reasons he is not here. So we are going to ask Andrés Nascimento and Hannerieke van den Hout to take place in this panel session.
Thank you. It was really great to hear you and the experience to 20 years old, more than 20 years follow patients is great, and we are going to have time to have questions and during the next session. So thank you for your presentation.
The experience is great. I'm sure not a lot of hospitals or centers have this so long experience. To listen to this professor is really a jewel. We're going to have a panel session. Javier hasn't been able to come, and so we wanted to share in this neuropediatrician group we wanted to make the most of the experience of Hannerieke van den Hout, and not only to approach it with the pediatrician, but also with adulthood. We have very good friends. I think it's not the neurologist, but the adult and the infrastructures. So we have to make sure that the decisions have, or the institutions have to have support, because they have to carry on working, but it is impossible if you do not have the other physicians that are coordinated. Although the neuropediatrician is going to do some things, if the team is not following, we need someone. So this we need the thrush and the help of all of us. I'm going to present you my slides, and the title is this one. I just wanted to be a guide, and what are we doing with our patients? What are the obstacles we face? And basically the option of opening the door to the new therapies. And where are we? I'm not going to talk about innovation because we have here an expert in innovation. I'm just going to address what we do. This is the angel jump. This is the fall, one of the greatest fall worldwide in Venezuela. And we also have seen Up. Who has not seen Up, the movie? And this fall is this one. I changed my life and I went to live to Barcelona. So I changed a location, and it is in this center, which is a reference center. I'm going to address some of the aspects that we have been dealing with throughout these 25 years. An experience is this one. We have to raise consciousness of the pediatrician, the neuropediatricians, about the early diagnosis. When we have a patient with a respiratory affection and it has 2-3 months, we cannot postpone the treatment because this is going to entail a certain number of issues. The diaphragm is involved, and to be able to deal with we have a respiratory failure, and they have a tracheotomy. And when you are dealing with the diagnosis, these patients has many affections, and we can worsen things. So the diagnosis is now earlier in many cases, but also we have learned about the neuromuscular disease with the spinal degeneration. So we have to have this early diagnosis. This is very much important. We have to raise consciousness of the primary care. A doctor, the pediatrician, has to detect those signs. We have to listen to the mother, because when the baby does not hold his head, when he has 2-3 months, when he starts to hold the head, and this is crucial. And in general, for us, if we look at all the patients that have weaknesses in their limbs, and with all these causes, neuromuscular causes, the Pompe patients will have another issue, which is the heart cardiopathy. This heart is going to be enlarged, and this is going to be a way of dealing with the diagnosis. We're going to look at that. We always tell the pediatrician to look at the heart. If you have this X-ray because it has a respiratory infection, look at the heart. And then they will be able to deal with the diagnosis. They know they have to have these blood drop, and they have a diagnosis. We can also use other methods. But as it has been said many times, it is a disease that is going to be have an impact on different parts of the body. It's not only limbs weaknesses, but all the muscles. And so therefore, that's why we have the multidisciplinary approach. We have to agree one another. We have to have a list of priority. What is the first thing we have done? For the Pompe patients, we have to look at the nutrition. And if I'm not caring about the nutrition, or if they're not having, they're getting the food they need, they can have problems of swallowing or when they eat. And so they said, well, it's going to the other way. They can have microaspiration of the food, and this is going to have an impact on the airways. And even though we have a treatment or a medication, I have no these into account. I will have the patient in the emergency ward and the UCI, and I will have to look at the way, and I will have to have a gastrectomy, because even though these patients are going to improve the mobility of the limbs, the swallowing is not the correct one. So we have to look at the different characteristics of the respiration. These patients cannot cough. If the patient cannot cough, he won't be able to get the mucus out, and the secretions are not going to get out of the body. They're going to be on the they're going to have really problems with a mere cold. If I haven't got control of the respiration of those patients, and whether patients are going to be in the office for a cough, for a cold, this is going to be getting worse, despite the fact they're going to receive the enzyme. The enzyme is not going to take care about the multidisciplinary treatment. That's for sure. So I will leave that for the table discussion, the panel discussion, variability in the clinical phenotype. It is a question I leave on the table. This is an example. A family. The first baby wasn't born in Catalonia, in my region, and when he is born, he's got a myocardiopathy and dies early in his early months, because we identify the failure and it gets worse and he dies. And then he has got a sister with the same conditions, and this girl, this baby, this infant, has got a lower hypothony, but has a myocardiopathy, and we have got patients, and in this case, it was very clear it was a more lenient form of the infantile type, so there is a weakness, and they have this heart failure. And we have in the first year they have this form, but they haven't got this cardiomyopathy. And from the point of view of the diagnosis, it is important that as they haven't got the cardiomyopathy, we do not think about Pompe as a first diagnosis, but we have to include Pompe in the first year of life because of these atypical forms or types. I leave it here. It is a question for the panel session and the panel discussion. These clinical heterogeneity on the basis of cases I have described, and they not only as a reaction to the therapy, but also the clinical manifestations that are different. This is this girl that is on the video is a little girl that has an enzymatic treatment. The evolution has been good. And it is interesting because these patients have changed house, and they were 3 or 4 months without the therapy, and there was a clear worsening of this condition, and she couldn't work. And then when the therapy starts again, she walks. So for the family, it was great. For all of us, it was great, but all the histories we find, not everything is so easy when they change house, and I cannot attend all my patients sometimes in the same way. Of course, they should come often, they shouldn't leave, and they shouldn't move, but it's not always the case. So this is an important aspect. The cream, positive or negative, I will introduce this during the panel discussion. We can maybe talk about that later on. This is a graph where we can see the two curves. The one on the upper curve is when we include the immunotherapy, and the one when we do not use this immunotherapy. All the groups of the patients that have in the double lines have received the enzyme. It seems that one is treated and not the other, but all of them are treated. So the impact that has the immunomodulation in those patients is huge, and we have to be cautious when interpreting previous surveys. The one that where we approved and the concept of the immunogenicity and the cream positive negative wasn't known in 2006. The 30 milligrams were approved instead of the 40 each 2 weeks of treatments, and there were no so many differences. But when looking back, we can talk about that. We saw that there were more patients in negative. But we learn on the way, and it is sometimes difficult to interpret studies that haven't been updated. We have to be more flexible. And also there is an important aspect, and it has been addressed, the short-term effect, the first years, and then the medium-term effect 4 or 5 years later. What are the factors that will show me what are the patients that are going to keep on walking after 2 years or after 7 years? Or what are the patients that are going to lose this walking faculty? We have the urine factors, or because of course the data we assess, they do not have the same doses that are given at the beginning. It's also difficult. And I'm just leaving a certain number of questions, as you can see. From the Pompe Infantile, I was, Jaume Colomer was my professor, and I follow his trail. And so this patient was the first Pompe disease kid, and he was the first one he saw. And he had 23 years of experience. I had 4 or 5 years experience. But he told me at that time we had seen many cases, but this form was the first one. He said it was quite a rare form. When you see the different literature, we see the different results of countries that are going to have many years of follow-up in other countries. But that's why it is so important to get together. If I've seen 4, the other doctor has seen 6, and the other 8, we can just put them together. And when there is an article that has been dealing with more than 100 patients, this is a really huge work. And so what comes from there is precious. So this was my first patient, and the first one for Jaume. So for us it was really shocking, the change of this patient. We knew that these patients are going to die before 2 years in 90% of the cases, and we saw this case. So this is incredible. Look, she's walking. She is holding. Is great. So I'm so happy. I've studied for that. So we had a follow-up, and it wasn't diagnosed. She wasn't diagnosed at the very beginning, but at 3 years old she has a respiratory infection. And when they deal with this infection, they can have this can have really severe consequences. This patient then could work at 4, 5, 6 years, but then she lost this ability, and she dies when she's 10 years old. And if we see this onset, I would have loved to have to be able to see what it was going to come, but it was difficult. I would have loved to interpret this prognosis, but it is difficult. Who knows? But then the early start of the treatment. Do we have to start with the treatment or not? And what is the dose of the treatment? And then we have another brother from this patient, this little girl, and we treated him at 6 hours live. So everything was ready, the medication was ready, everything was ready. So we started the treatment 6 hours after the birth. So if I had it was planned, so the birth was planned, so everything was ready, all the paperwork was ready, and it's not easy. So 6 hours we started the treatment, so great. But we were very happy. But I have to say that we had the same evolution as the sister. He started to work at 14, 15 months. He had a hair lip that evolved correctly. And he also started with respiratory affections, and even though he was really well cared after, and he gets into the hospital, invasive treatment, physiotherapist, everything. And then we saw the results of the high dose. Well, after all these great efforts during months, we wanted to have the authorization to increase the dose. Of course, we increased the dose, actually, and here it was quite okay. He couldn't walk there, but then 4 months after the increase of the dose to 40, he recuperated the walking. But it was just an instability. But it is clear we needed more enzyme in the infantile form of Pompe. We will deal with that. We will address that during the panel discussion. But of course, the evolution is not perfect, even though when we use high doses, it was analyzed, as you can see on this paper. But this so that's how we could increase the dose. And I had to update my data. I wasn't going to put the data of the previous speaker. I had the data of other groups, as you can see here. This is the evolution, 7 years evolution. As you can see, the patients that can walk, and we have 50% of these patients that are able to walk. And then, despite the fact they walk, I'm going to have a percentage of patients that are losing this ability. As, for example, the other abilities are going to be lost with those patients. I haven't got a flat line, and this is important to bear in mind. This has to be known by the multidisciplinary team and the family. So more or less, we have been addressing that. One of the limitations of the enzyme is this one. It is sometimes not getting to all the tissues. We have an impact on heart. We have had 5 infantile Pompe. 2 have died. It was in the first years.
So this story at cardiac level is quite typical. Arrhythmias are very frequent. Even though we can recover these, arrhythmia have to be followed. We have to take care of that. We have to be very aware of the neurocognitive part, because we demonstrated that this is accumulated in the central nervous system. So if the enzyme doesn't cross the barrier, we have to follow all these elements. The neurocognitive ability is good, but the expressive language is important too. So we're going to leave it to the end of the round table, because I would like to talk about this whole part that was mentioned in the previous talk, the importance of ERT, new therapies that can be very important, and many efforts have been carried out to improve the entrance of this enzyme and various mechanisms that are combinations so that we need more enzyme through the barrier. So this is the physiological process, not the enzymatic process. This is what our body does to produce enzymes and do not produce it directly. The alpha-glucosidase is an enzyme that has been following a cursus and all the degrees. It's not direct. GAA has an evolution, and there's a specialization. There is a protein with a reticule in the Golgi glucose. And little by little, this GAA has specialized in order to have its own function. So we want to put an enzyme, but it's not a simple one. This enzyme has going through studies and has been following a cursus and a curriculum. So here we have the various support people here: speech therapist, cardiologist, pneumology, psychologist, social work, family support, school adaptations, family associations. All our patients have a treatment. Maybe there's not a cure yet, but all our patients can be treated. And here there's a festival of people, many stakeholders, many participants. We're just a part. This is the caregiver chain. And then the treatment is open up new windows for hope. This is the team in working on this. Thank you very much. And we'll leave the floor to our colleague, Hannerieke.
You have this.
Okay, I feel I'm taking too much time. Oh, wait, let's put this off. I'll put this here. Okay, good. I feel like I'm here too much. I think I should give you the stage, really, to ask questions. So what I'll do, I'll give, as quick as I can go, an introduction to lentiviral gene therapy for modified stem cell transplantation, and the stage in which it is right now, because it's not in patients yet, as you know. And then I hope to hear questions from you, and I'll be here around the whole day, and just approach me. Unfortunately, my Spanish is not very good, but we can try to understand each other. We'll find a way. Okay, so lentiviral gene therapy, modified stem cell transplantation. I've gone to the start with you. First, I want to look at the forms of gene therapy that are currently available in the world, and what are the pros and cons of the different gene therapies. Well, if we first look at the right side, you see AAV gene therapy. That means adenovirus-associated gene therapies. These gene therapies are done, which we call as scientists, in vivo. That means that I will take the virus which is modified and weak and will not make you ill, but can cure you, and I will directly give it to you, either in the bloodstream or directly in the brain, so in different routes. There are many serotypes of adenoviruses, and each serotype homes to a certain organ. So it's important that you find the right phenotype. You want to the gene therapy to either home to the muscles or the muscles and the brain. Adenoviruses are not integrated. They do not go directly to your genetic material, your genetic information. Instead of that, they remain separately in the cells in a form which is called episome. The good thing is that they don't interfere with your genetic information. They don't go to the wrong positions and don't cause harm to that. But as they remain in a specific part, when the cells grow in number, some cells may end up without the episome, without the new information, the cure, and others will. So over time, the effect of gene therapy can wane. And as there are a lot of adenoviruses in the world, and you can have them when you have a cold, an airway infection, a lot of us will already have antibodies against adenoviruses and therefore cannot be treated anymore with adenoviruses. In adenoviruses, you change, as I said, a specific organ. That can be the muscle, it can be the brain, but you can also change, for example, the liver, and then build the liver as a kind of a production facility for the enzyme, which is then secreted into the bloodstream. So it holds hope, but it's not for everyone. If you have antibodies, you cannot have it. And when you're treated with it, you can make antibodies, and therefore the treated cannot be repeated. So, if you then turn to the right side, to the lentiviral gene therapy, that is done as we called ex vivo, outside your living system. So I take cells of the patient, I modify them with lentiviral gene therapy, and then give them back to the patient. They will home to the hematopoietic system. Antibodies are generally not present, they are absent against lentiviral gene therapy, so you can give it to more patients in your population, but they integrate in your own genetic information, in your DNA. So that means that there is a slight risk, for which we always try to control and which we're studying very hard, but there's a slight risk that it will go into a wrong part of your genetic information. And as we use the bone marrow, the blood-forming cells, there is a risk of, for example, leukemia. It is small, but it is there. What diseases can be treated currently with gene therapy? Well, lentiviral modified stem cell transplantation is available for another lysosomal storage disorder, and it is called metachromatic leukodystrophy. It is also available for a blood disease, beta thalassemia, and for a disease of the immune system, adenosine, well, let's call it SCID, very long name. So for these diseases, in some of the countries of the world, there's also already a lentiviral gene therapy available right now. For others, it's still in clinical trials. Lysosomal storage disorders like MPS 1, MPS 3, just currently in Manchester, a study on MPS 2 started. On paroxysmal diseases like ALD, adrenal leukodystrophy, and in Pompe disease. In Pompe disease, it's still in the trial phase in mice, and I will attend to that. So this I already explained to you. So the patient, we take the cells, we treat the cells, we make space in the bone marrow, give back the patient its own cells, which are now healthy, and they become the production facility for the rest of the body. As we treat the patient with busulfan, the treatment can also go to the brain as the blood-brain barrier is broken. So thereafter, the bone marrow will produce the blood cells, especially leukocytes. The leukocytes will go into the bloodstream and they will secrete enzyme. The enzyme can then go to organs, and in Pompe disease, that's the muscle and the heart muscle in classic infantile patients. And whereas for enzyme replacement therapy, the blood-brain barrier is intact, and the enzyme cannot enter the brain, it is opened by busulfan for the stem cell transplantation, and cells can go into the brain. So as I explained you, right now we are treating mice, but we're on the right track, and that's what I want to explain to you. So this is our first version of the lentiviral gene therapy. It's called a construct, and it's on the upper corner, the blue boxes. And on the lower corner, we show you in the amount of glycogen in healthy mice, the black box, WT, so that's the healthy mouse, and also in the knockout mice. And then the white box are the knockout mice treated with a stem cell transplantation without gene therapy. And the gray boxes are the knockout mice, so the Pompe mice treated with the actual gene therapy. And what you can see is the amount of glycogen goes down. It goes down on the left side in the heart, in the diaphragm, in the box with QF, the quadriceps muscle, so that's your muscle here. But it did not enter the brain. So that was a setback because we really wanted to enter the brain. So we improved the gene therapy. And what we did, we added a tag called the IGF-2 tag. And on your blood-brain barrier and also on the cells in the brain, you have receptors for the IGF-2 tag. So that means that the enzyme is actually brought actively over the blood-brain barrier in the cells. And with this improved vector, we can see on the left side that in those patients treated with the old vector, the glycogen concentration was still high. But if we look at the white boxes, you can see that the glycogen concentration goes farther down. And you can also see in the graph of the brain that even in the brain, we could decrease the amount of glycogen. So we did make a gene therapy, and we improved it, and we're now able to, even in the brain, decrease the amount of glycogen. So in knockout mice, it works. And now we have to make the translation from the knockout mice to the patient. And that seems like a very small step, but actually it's a very big one, because now we have to be able to make the treatment very good, stable, in a continuous way. We have to be sure that it's super safe, that it will not integrate on the wrong side of the genomes and will not cause leukemia. So there's a lot of the work to be done there. Then we have to design a study in which we are sure that we can prove that the therapy is safe, phase 1-2 trial, and thereafter we have to choose endpoints to be able to show that it is really efficient. And that is important. And there's another challenge, because more and more we see that the new therapies, innovative therapies for rare diseases, are enormously expensive. And we also see that gene therapy for rare diseases are even more expensive. And this is a real big threat for the treatment of rare diseases, I think. Because more and more governments are not really inclined to reimburse all the treatments because we do not have all the money of the world. It would be good if we had, but we don't. And also companies, pharmaceutical companies, seeing this, they are holding back. They think, I can develop this new treatment, but if I can't bring it to the market, why would I? If people are not, if governments are not going to reimburse it, then it will be a waste of money. So they hold back. So we have started a very ambitious project in which we will try to develop lentiviral modified stem cell therapy in the university. We will not bring it to the pharmaceutical companies as long as we can, and we will try to do it at an affordable price. And it's very ambitious. We want to learn two things. One, we want to see if we can do it. And two, we want to learn how much does the development of such a therapy really, really cost, because there's not much insight on that. So we're well on our way of developing a gene therapy, lentiviral gene therapy, modified human stem cell transplantation in knockout mice. We are now going gradually to clinical trials. We think this holds the promise to correct Pompe disease in late onset patients and in classical infantile patients. But for the classic infantile patient, it's important because it can also reach the brain. And we are now translating that to clinical trials. Thank you.
We can see here. Waiting for the question. Esperando las preguntas, yo creo que...
Waiting for the questions. I would like to take advantage of the situation to have questions from the people here.
¿Alguna pregunta?
Any questions?
Adolfo.
Adolfo. Manu? Yes. Can you hear me? Thank you very much. Thank you for attending. To all the speakers in general, and I know that your agenda is very busy. And a question for Javier de las Heras. In fact, he wasn't able to attend due to a medical problem. It's a pity, because he's an expert on infantile Pompe. I'll try to ask two questions. One, for the adult Pompe experts, because you spoke about doses and dosage, 40 for adults too. I know that in Spain, adults are not receiving 40 milligrams per kilo, but I know that other patients in other countries are receiving 40 as a dosage. Very briefly, what could be the criterion? What about in medical insurance? Because in other countries, it's not in Social Security. In the US, it's different. So maybe with the additional insurance, we can pay it for it. And then my second question about therapy. You're studying new therapies. Is this addressed to the nervous system? It's just for the musculoskeletal, cardiac, and then go through the blood-brain barrier? Or does it go to the nervous system? Is it possible? Thank you.
Okay, I'll put off my bit difficult to... Okay, good. The first question on the dose. In the Netherlands, adult patients also do not get 40 mg/kg per week. They get 20 mg/kg per 2 week. I must say that's also because it's not reimbursed. If we would have more money, probably we would increase the dose, but we can't. I know in the US that the situation is different, and that some patients are on 40 mg/kg every 2 weeks or weekly, on Myzyme, that is all. And they see that they have published that it improves the outcome. I think our insight in higher doses in late onset patients is yet not very far and still growing. What could be reasons to higher the dose? That's difficult because there's so little experience. Of course, when patients decline, it's always important to see why are they declining. So mostly late onset patients do not develop high antibody titers, but some do, and therefore before doing anything to a dose you should check that. 2, and that Stephen will talk about a little bit later, is this patient moving, or has he been ill and did he not move? So then things like that can be improved. How is the lifestyle of the patient? Because exercise is one, but good food is another, and good weight is important because the patient has to carry his weight for the whole day. When all of that is good, then the dose could be heightened, increased, if there's a possibility of that. 2, we know that patients with 2 severe mutations, so not the IVS1 mutation and another mutation, but 2 severe mutations do worse. And we also know that patients who have an IVS1 mutation, a specific mutation, and another mutation, in combination with something which is called a modifying factor, also do worse. What we could study, but that really needs some more study, is that those groups maybe need higher doses. That's maybe part of an answer to your question. And then the second question, what our current form of gene therapy does, I think, is probably 2 things. 1, after treatment of busulfan, the blood-brain barrier gets open, the stem cells go into the brain, and we think that what they do there is they form microglia cells, and those cells will then secrete the enzyme replacement therapy and correct the other cells. Therefore, they directly treat the brain and therefore part of the central nervous system. What will happen to the peripheral nervous system, we don't know exactly, because you have the brain, that's your central nervous system, but you also have all the nerves to the rest of your limbs. What will happen there is not totally clear yet. It remains to be seen if we can correct those cells, and we very well might not be able to do that. And we do not know what the peripheral nerves and the peripheral nerve system, if there is a factor there that adds to the distal muscle weakness in classic infantile patients. Did I answer your questions?
Thank you very much. I could ask you many other questions, but if anybody in the room would like to take the floor, because I could do a monologue here. I have a lot of questions, in fact. I was talking about the nervous system because this is affecting us also, not just the muscles. In infantile Pompe, the impairment is at cognitive level too. The involvement is not just for our muscles. That's something that you see from the outside, but there are other involvements in our bodies. And then you spoke about the blood-brain barrier, because it opens the door. What does it mean? You see the possibility to do gene therapy and using ERT in combination. Would it be impossible, just ERT plus gene therapy? Is that possible?
That's possible. We actually studied it in mice, and we found that after gene therapy, the mice became, they did not have an antibody response to the enzyme replacement therapy yet. Yes. So yes, we think that in combination or after gene therapy, you can also again start enzyme replacement therapy. Yes.
Adolfo tenía una pregunta.
A question for Adolfo. Thank you very much for your excellent presentations. I have 3 quick questions. First, what is the situation in a neonatal diagnosis? What is the state of the art? Apparently, and despite what you told us, the early diagnosis is complicated. It would be so important for infantile Pompe. My second question, what do we know about factors that are phenotype modifiers before treatment? Why these differences? What do we know about these modifying factors? And my third question for Hannerieke, what about introducing cell therapies in the nervous system? Do you have physical media, HIFU, to open up this barrier through ultrasound? Opening the barrier just in this moment with HIFU, with ultrasound, instead of using drugs. Maybe I can start with it. And then you can continue, because you know more about these 3 questions than me. Our experience. What about the screening? We had some screenings, and we are now pushing it, but we didn't find anything. The 6 hours and the 2 weeks, this is a crucial point for diagnosis. When I mentioned the difference between 6 hours after life, and there's some studies, and I'd like to ask you about the studies, the prenatal diagnosis with enzyme treatment. I know it's been used in some cases. I've read it in some of your articles. I think the great problem that we have now is that we need to get to the early diagnosis as soon as possible. It's obvious. And the screening is meaningful. But the problem of our screenings is that we're going to identify a late onset population where the management of this late onset population is going to be more complex. Because we don't know what is the protocol to implement, because people will not have no symptoms until 20 years of age, because I'm giving just an initial dosage. The family is going to be transformed because there is an early diagnosis of this rare accumulation disease. This management is very complex, and we need to select the group of people, especially for severe forms of Pompe infantile disease, with enzymatic screening, and we need the protocol, especially for those that have more than 5, more than 20%. I don't have experience about that according to severity, but I know that this Taiwan experience that has been published has been very helpful. But there are other studies carried out in other countries. The great benefit of having this screening of serious, severe patients is that you don't find a situation in which the patient is under an intensive therapy. In 2 weeks they have tracheotomy, and if this patient, if I had made a diagnosis at 15 days of age, the patient would have never gone through that terrible situation. It's exponential. We need to do early diagnosis, but we need to know how. We don't know what's going to happen after 3, 7, 10 years, but screening is fantastic for severe forms, and we would have a great impact if we were capable of aligning that. And now I'm going to let you respond to the other questions.
Maybe adding to that, yes, Taiwan has shown that it really works well, and they've even shown that if you only have a difference of a few days, that already makes a difference in the outcome. So days matter. What they do in Taiwan, and they also have prenatal screening in the US in some regions, and they also have prenatal screening, I think, in one region in Italy. What they do is they do an enzymatic screening and then get the patients into the hospital to see if they have Pompe disease or they do not have Pompe disease. So this changes the start of life for many patients and for many people with healthy children. So they have like a very big shock at the beginning of life. And in the Netherlands, the government is very careful with that. And you should not have too many patients going to the hospital, what they call false positive. So they have healthy children. Now they think they might have a child with Pompe disease and they have to come to the hospital. So you have to keep the number of false positive people really down. In the Netherlands, that is, I don't know, the Spanish situation. So what we are now trying to develop is a way of screening enzymatically and adding an extra test, a second tier, to it, either genetically or through a biomarker, which we may have potentially found, and we are still studying that. So that's one. I think for your question on the blood-brain barrier, be it high frequency ultrasound, low frequency, yeah. So opening it up. Yes, that potentially might be a way, but you still have to make space in the bone marrow, and you have to get adequate chimerism. So you have to get enough new corrected bone marrow forming cells in the bone marrow. And recently there was a trial on Fabry disease and lentiviral gene therapy, and they used another vector, which might be the reason, but they also used a lower amount of busulfan to make room in the bone marrow, and they didn't get enough enzyme into the bloodstream, so that trials was stopped. So you need busulfan, so you need an agent chemotherapy to make space in the blood marrow anyways, and you need an adequate amount of busulfan in the bone marrow to get enough space in the bone marrow, and therefore using another method to make the blood-brain barrier open might be a way, but potentially is not needed. But it is an idea, yeah.
Some other modifiers of phenotype in patients carrying the same mutation.
Yeah. So what I told you is there is a genetic modifier in late onset patients, and that changes the disease. If you have it, you have a more serious course of the disease. So for the late onset population, we have some information. We know that any combination with the IVS1 will give you a little bit of a better prognosis. We know that if you have the IVS1 and a genetic modifier, that will worsen your prognosis. And we know if you have two severe mutations, that this will lead to a more rapid start of the disease and probably a more progressive disease. When we look at the classic infantile populations, we used to look at it as a very homogeneous group. Now they are treated, we learn that children have, that there's variation. There is variation in the effect of the disease due to the formation of antibodies. And formation of antibodies occurs more in CRIM negatives and less in CRIM positives. But we also know that factors like an intercurrent illness, when the child has to be in bed for a longer time, that can lead to muscle weakness, and that muscle weakness is not always gained afterwards. We know, but looking at the population, we now see that there's even more variation, which we cannot totally explain by antibody formation and intercurrent illness. And we see that when you look in the brain, that patients with 2 classic infantile severe mutations and really low enzyme activity, that some patients do not have brain involvement. Now, to be very honest, we don't understand yet. We don't understand why some do and others don't, and why those patients that have some brain involvement, some patients do really good, they go to schools, if some patients even go to university, they are able to learn, while others have a far more progressive course of brain involvement and develop epilepsy. To be very honest, we're still learning.
Una pregunta.
Sí, hola. Mira, yo...
Morning. My girl is 4 years old and she was diagnosed when she was 2 months old. But it was at random, because I would like to know if there is a kind of protocol in hospitals and among pediatricians for what you have mentioned about the specific characteristics of the Pompe disease. If they have in the maternity hospital certain a list of criteria, because my daughter, they thought it was a urine infection, and she was going home, but when she thought they had a murmur, she looked at they looked at the heart, and she had an enlarged heart. So then onwards, they had a lot of tests done, and it's because we had those tests, and she was diagnosed. Otherwise, no one was aware of this disease, and this was 4 years ago. So I would like to know whether there is a protocol in pediatricians or physicians, doctors in general, because this was 4 years ago. No one was aware of that. Well, when these are rare disease, we can talk afterwards, of course, but it is a diagnostic challenge many times, because nor the cardiologist, the pediatrician, or the general pediatrician or have a specific, have been trained for this rare disease. That we have, of course, raised consciences about pediatrician. They do not have to know all the rare disease, that's for sure, but they have to be aware of the alerts. The patients that have hypotony, that have they are weak, they fall a lot. In a patient that has a cardiomyopathy, when there is some kind of heart affectation, and we have neuromuscular references. Of course, we have certain alerts. And of course, what it's harder, I believe, is that from the first symptom to get to the expert specialist, and this is difficult. It is a labyrinth, and we try to have good training, and the pediatrician have to be in touch of hospitals, but it is our job to disseminate all the information. Nowadays, we have tried to talk about the rare new muscular diseases, and as they are therapies, it is important to be able to have this early diagnosis, because it is going to change the course of the disease quite a lot. So we can talk afterwards privately, and but it is a challenge. These rare diseases are a challenge for all the countries, because it takes time to take them to the reference center. In Barcelona, we have several reference centers, and it depends upon where he is born, in Lleida or a small town, the circuits are not the same. But we have the national reference networks. We have centers with a high expertise. But we have to carry on working, and we have to have campaigns, and I think we have to work a lot on that. I don't know if you have or face the same difficulties.
Despite of all our knowledge, we're very much on the same page. So it's a rare disease. Pediatricians have to know a lot of diseases. And this is one rare disease within that big group. And that is exactly why newborn screening for those diseases that are treatable is so important. So that is also why it's so important that we solve the problem of newborn screening in Pompe disease and find a way of putting a second test with it to be able to really find the classic infantile patients and see if we want to find late onset patients, which might very well get into problems when they are 70 and then they know all their life that there is an upcoming impending illness. So I'm very much on the same page as Andrés. Yeah.
One last question, Manu is... No?
No.
Question in the coffee.
Vamos a hacer una pausa.
We're going to stop for a break, and we come back at 10:02. Thank you.
De todas maneras, aquellos que tengáis...
Además, se conoce el orden de afectación radiológica de los músculos en resonancia magnética en la enfermedad de Pompe, siendo algunos de los primeros afectados la lengua, a pesar de no presentar síntomas precozmente, o los músculos subescapulares. Entre los primeros afectados también se distinguen algunos músculos de los muslos, tales como los aductores, isquiotibiales y cuádriceps, así como los músculos de la pelvis, los paraespinales o los oblicuos abdominales. Para una correcta evaluación de la debilidad muscular es necesario realizar una exploración muscular en la que el músculo explorado esté en posición adecuada y evitando el efecto de la gravedad. Realizar una exploración funcional como la maniobra de Gowers. Evaluar cómo el paciente salta, sube escaleras o se mantiene a la pata coja, entre otras. Y anotarlo en su historial para poder llevar a cabo un seguimiento. Además, hay otras técnicas que se pueden emplear, como la resonancia magnética, que resulta de gran utilidad en el diagnóstico diferencial, la biopsia muscular, que indica patología cuando se observan vacuolas cargadas de material Pas positivo y una fosfatasa ácida alterada, pero que puede ser normal en un 30% de los casos, y el estudio en gota de sangre seca de una alta sensibilidad. No obstante, siempre requerirá de un estudio de confirmación genética posterior. La insuficiencia respiratoria temprana es una manifestación típica de la enfermedad de Pompe de inicio tardío y la principal causa de morbimortalidad. En algunos pacientes, esta es la primera manifestación de la enfermedad y un tercio requieren ventilación mecánica no invasiva antes de la pérdida de la marcha. En un principio solo se requiere ventilación mecánica nocturna, llegando a necesitarse las 24 horas según avanza la enfermedad. Estas manifestaciones respiratorias afectan a la musculatura abdominal, orofaríngea, intercostal, diafragmática. La debilidad en la musculatura expiratoria se traduce en tos ineficaz e infecciones respiratorias de repetición. Si hay debilidad orofaríngea, puede haber eventos obstructivos que provocan episodios de desaturación de oxígeno. En el caso de debilidad intercostal y diafragmática, aparece ortopnea, síntoma de alarma que sugiere debilidad muscular respiratoria y un patrón ventilatorio superficial que da lugar a hipercapnia nocturna e hipoventilación alveolar con acumulación de carbónico. La desaturación de oxígeno, la hipercapnia nocturna y la hipoventilación alveolar derivan en somnolencia diurna, cefalea matutina y sueño no reparador. Las pruebas que se suelen realizar para identificar la insuficiencia respiratoria son pruebas funcionales como la capacidad vital forzada con una baja sensibilidad que mejora realizando la prueba en decúbito, u otras pruebas como son la presión inspiratoria máxima o la presión expiratoria máxima. También se realizan estudios del sueño como la pulsioximetría nocturna, la poligrafía y la polisomnografía, imprescindibles para diagnosticar episodios de apnea e hipoventilación. Si no se trata, la enfermedad de Pompe es inexorablemente progresiva y lleva a un deterioro significativo y a un aumento de la discapacidad, incrementando la morbilidad y la mortalidad temprana. En el caso de la forma infantil, casi siempre provoca la muerte antes de los 2 años de edad. La evolución natural de la enfermedad supone que cada año que transcurre desde el diagnóstico se incrementa un 8% en la necesidad de soporte respiratorio, un 13% en la necesidad de silla de ruedas. Los objetivos del tratamiento son detener y/o reducir el avance de la enfermedad, con un beneficio en las funciones motora y respiratoria. Sin embargo, el tratamiento es crónico y requiere de una supervisión médica multidisciplinar. Además, al ser intravenoso, la administración es hospitalaria cada 2 semanas y dura aproximadamente entre 6 y 10 horas en función del paciente. La enfermedad de Pompe es un trastorno neuromuscular progresivo, incapacitante y poco frecuente que tiene un fenotipo reconocible. Su forma infantil se caracteriza por presentar cardiomegalia, hipotonía y una debilidad muscular generalizada. La forma de inicio tardío presenta una CPK elevada, debilidad muscular y afectación respiratoria temprana. Ante su sospecha, se debe medir la actividad enzimática en gota seca, un método ideal de screening, mientras que el diagnóstico definitivo se consigue mediante estudio genético que confirme una mutación en cada alelo. Un tratamiento temprano es fundamental para reducir la progresión de la enfermedad. Además, resulta imprescindible la participación de un equipo multidisciplinar en su manejo y tratamiento para obtener mayores beneficios y mejorar la calidad de vida de los pacientes. Este equipo suele estar formado por especialistas en neurología, neumología, cardiología, psicología, nutrición, fisioterapia y logopedia, aunque cada paciente necesita un abordaje personalizado. ...15 de abril, Día Internacional de la Enfermedad de Pompe. La enfermedad de Pompe es una enfermedad genética provocada por alteraciones en el gen que codifica la proteína alfa-glucosidasa ácida, la única capaz de degradar el glucógeno de los lisosomas. Esta enfermedad presenta 2 formas. La enfermedad de Pompe de inicio infantil, que aparece en niños menores de 1 año y con una actividad enzimática menor al 1%, y la enfermedad de Pompe de inicio tardío, que se caracteriza porque la actividad enzimática está entre el 1 y el 30% y no cursa con cardiopatía. A pesar de ser una enfermedad que afecta a todos los tejidos del cuerpo, lo hace especialmente en los músculos, de forma que el glucógeno se almacena inicialmente en los lisosomas, los cuales acaban rompiéndose. Esto hace que el glucógeno, junto con el resto de enzimas lisosomales, se libere al citoplasma de la fibra muscular, lo que provoca una disrupción mecánica y una disfunción lisosomal que, si se agrava, puede llegar a ser irreversible. De forma progresiva, los músculos acumulan vacuolas llenas de glucógeno y material autofágico, haciendo que la fibra muscular vaya perdiendo su función hasta su necrosis y sustitución por tejido graso y conectivo. Esto se va a traducir en una serie de signos y síntomas característicos de la enfermedad de Pompe, que marcarán la evolución de la enfermedad, dando lugar, en ausencia de tratamiento, a una discapacidad permanente. En el caso de la enfermedad de Pompe de inicio infantil, IOPD, los síntomas comienzan a los pocos meses de vida. Los pacientes suelen presentar cardiomegalia, hipotonía, debilidad muscular, dificultad respiratoria, dificultad para alimentarse y retraso del crecimiento. En el caso de la enfermedad de Pompe de inicio tardío, LOPD, las principales manifestaciones clínicas pueden ser una CPK alta, acompañada de síntomas inespecíficos, debilidad muscular proximal, sobre todo debilidad de cinturas, e insuficiencia respiratoria temprana. En cuanto a la hipercecaemia, es importante saber que una CPK normal no descarta una enfermedad de Pompe, aunque es excepcional. Suele estar alterada dentro del rango de 300 y 3000. En ocasiones puede venir acompañada de elevaciones de las aminotransferasas y no suele cursar con rabdomiólisis. Al ser una miopatía, la enfermedad de Pompe de inicio tardío se caracteriza por cursar con una debilidad muscular fundamentalmente axial, en la que destaca la hiperlordosis, y por afectar inicialmente a las extremidades inferiores, estando implicadas sobre todo zonas proximales y compartimentos posteriores. Otros signos posibles son la ptosis palpebral, la escápula alada leve y simétrica y la macroglosia. Además, se conoce el orden de afectación radiológica de los músculos en resonancia magnética en la enfermedad de Pompe, siendo algunos de los primeros afectados la lengua, a pesar de no presentar síntomas precozmente, o los músculos subescapulares. Entre los primeros afectados también se distinguen algunos músculos de los muslos, tales como los aductores, isquiotibiales y cuádriceps, así como los músculos de la pelvis, los paraespinales o los oblicuos abdominales. Para una correcta evaluación de la debilidad muscular es necesario realizar una exploración muscular en la que el músculo explorado esté en posición adecuada y evitando el efecto de la gravedad. Realizar una exploración funcional como la maniobra de Gowers. Evaluar cómo el paciente salta, sube escaleras o se mantiene a la pata coja, entre otras. Y anotarlo en su historial para poder llevar a cabo un seguimiento. Además, hay otras técnicas que se pueden emplear, como la resonancia magnética, que resulta de gran utilidad en el diagnóstico diferencial, la biopsia muscular, que indica patología cuando se observan vacuolas cargadas de material Pas positivo y una fosfatasa ácida alterada, pero que puede ser normal en un 30% de los casos, y el estudio en gota de sangre seca de una alta sensibilidad. No obstante, siempre requerirá de un estudio de confirmación genética posterior. La insuficiencia respiratoria temprana es una manifestación típica de la enfermedad de Pompe de inicio tardío y la principal causa de morbimortalidad. En algunos pacientes, esta es la primera manifestación de la enfermedad y un tercio requieren ventilación mecánica no invasiva antes de la pérdida de la marcha. En un principio solo se requiere ventilación mecánica nocturna, llegando a necesitarse las 24 horas según avanza la enfermedad. Estas manifestaciones respiratorias afectan a la musculatura abdominal, orofaríngea, intercostal, diafragmática. La debilidad en la musculatura expiratoria se traduce en tos ineficaz e infecciones respiratorias a repetición. Si hay debilidad orofaríngea, puede haber eventos obstructivos que provocan episodios de desaturación de oxígeno. En el caso de debilidad intercostal y diafragmática, aparece ortopnea, síntoma de alarma que sugiere debilidad muscular respiratoria y un patrón ventilatorio superficial que da lugar a hipercapnia nocturna e hipoventilación alveolar con acumulación de carbónico. La desaturación de oxígeno, la hipercapnia nocturna y la hipoventilación alveolar derivan en somnolencia diurna, cefalea matutina y sueño no reparador. Las pruebas que se suelen realizar para identificar la insuficiencia respiratoria son pruebas funcionales como la capacidad vital forzada con una baja sensibilidad que mejora realizando la prueba en decúbito, u otras pruebas como son la presión inspiratoria máxima o la presión expiratoria máxima. También se realizan estudios del sueño como la pulsioximetría nocturna, la poligrafía y la polisomnografía, imprescindibles para diagnosticar episodios de apnea e hipoventilación. Si no se trata, la enfermedad de Pompe es inexorablemente progresiva y lleva a un deterioro significativo y a un aumento de la discapacidad, incrementando la morbilidad y la mortalidad temprana. En el caso de la forma infantil, casi siempre provoca la muerte antes de los 2 años de edad. La evolución natural de la enfermedad supone que cada año que transcurre desde el diagnóstico se incrementa un 8% en la necesidad de soporte respiratorio, un 13% en la necesidad de silla de ruedas. Los objetivos del tratamiento son detener y/o reducir el avance de la enfermedad, con un beneficio en las funciones motora y respiratoria. Sin embargo, el tratamiento es crónico y requiere de una supervisión médica multidisciplinar. Además, al ser intravenoso, la administración es hospitalaria cada 2 semanas y dura aproximadamente entre 6 y 10 horas en función del paciente. La enfermedad de Pompe es un trastorno neuromuscular progresivo, incapacitante y poco frecuente que tiene un fenotipo reconocible. Su forma infantil se caracteriza por presentar cardiomegalia, hipotonía y una debilidad muscular generalizada. La forma de inicio tardío presenta una CPK elevada, debilidad muscular y afectación respiratoria temprana. Ante su sospecha, se debe medir la actividad enzimática en gota seca, un método ideal de screening, mientras que el diagnóstico definitivo se consigue mediante estudio genético que confirme una mutación en cada alelo. Un tratamiento temprano es fundamental para reducir la progresión de la enfermedad. Además, resulta imprescindible la participación de un equipo multidisciplinar en su manejo y tratamiento para obtener mayores beneficios y mejorar la calidad de vida de los pacientes. Este equipo suele estar formado por especialistas en neurología, neumología, cardiología, psicología, nutrición, fisioterapia y logopedia, aunque cada paciente necesita un abordaje personalizado. ...15 de abril, Día Internacional de la Enfermedad de Pompe. La enfermedad de Pompe es una enfermedad genética provocada por alteraciones en el gen que codifica la proteína alfa-glucosidasa ácida, la única capaz de degradar el glucógeno de los lisosomas. Esta enfermedad presenta 2 formas: la enfermedad de Pompe de inicio infantil, que aparece en niños menores de 1 año y con una actividad enzimática menor al 1%, y la enfermedad de Pompe de inicio tardío, que se caracteriza porque la actividad enzimática está entre el 1 y el 30% y no cursa con cardiopatía. A pesar de ser una enfermedad que afecta a todos los tejidos del cuerpo, lo hace especialmente en los músculos, de forma que el glucógeno se almacena inicialmente en los lisosomas, los cuales acaban rompiéndose. Esto hace que el glucógeno, junto con el resto de enzimas lisosomales, se libere al citoplasma de la fibra muscular, lo que provoca una disrupción mecánica y una disfunción lisosomal que, si se agrava, puede llegar a ser irreversible. De forma progresiva, los músculos acumulan vacuolas llenas de glucógeno y material autofágico, haciendo que la fibra muscular vaya perdiendo su función hasta su necrosis y sustitución por tejido graso y conectivo. Esto se va a traducir en una serie de signos y síntomas característicos de la enfermedad de Pompe, que marcarán la evolución de la enfermedad, dando lugar, en ausencia de tratamiento, a una discapacidad permanente. En el caso de la enfermedad de Pompe de inicio infantil, IOPD, los síntomas comienzan a los pocos meses de vida. Los pacientes suelen presentar cardiomegalia, hipotonía, debilidad muscular, dificultad respiratoria, dificultad para alimentarse y retraso del crecimiento. En el caso de la enfermedad de Pompe de inicio tardío, LOPD, las principales manifestaciones clínicas pueden ser una CPK alta acompañada de síntomas inespecíficos, debilidad muscular proximal, sobre todo debilidad de cinturas, e insuficiencia respiratoria temprana. En cuanto a la hipercecaemia, es importante saber que una CPK normal no descarta una enfermedad de Pompe, aunque es excepcional. Suele estar alterada dentro del rango de 300 y 3000. En ocasiones puede venir acompañada de elevaciones de las aminotransferasas y no suele cursar con rabdomiólisis. Al ser una miopatía, la enfermedad de Pompe de inicio tardío se caracteriza por cursar con una debilidad muscular fundamentalmente axial, en la que destaca la hiperlordosis, y por afectar inicialmente a las extremidades inferiores, estando implicadas sobre todo zonas proximales y compartimentos posteriores. Otros signos posibles son la ptosis palpebral, la escápula alada leve y simétrica y la macroglosia. Además, se conoce el orden de afectación radiológica de los músculos en resonancia magnética en la enfermedad de Pompe, siendo algunos de los primeros afectados la lengua, a pesar de no presentar síntomas precozmente, o los músculos subescapulares. Entre los primeros afectados también se distinguen algunos músculos de los muslos, tales como los aductores, isquiotibiales y cuádriceps, así como los músculos de la pelvis, los paraespinales o los oblicuos abdominales. Para una correcta evaluación de la debilidad muscular es necesario realizar una exploración muscular en la que el músculo...
Vamos sentando para empezar, que vamos con un poquito de retraso. Bienvenidos de nuevo, continuamos.
Welcome again. We are going to address the role of exercise in management of Pompe disease. Physical activities and Pompe, is this compatible? According to the specialists, it is good. These exercises can ease up the elimination of the glucogen, and this exercise has to be individualized and well managed. But we will talk with Stephen Dando of the University of Cardiff in UK. He will talk about this role of exercise in Pompe disease. Yours is the floor.
My name's Stephen Dando. I'm a physiotherapist and I'm a lecturer at Cardiff University, where I specialize in the role of exercise in the management of a whole range of neurological conditions. So I'm very excited to be here today to talk to you about this particular subject. It's one that I'm very interested in, and I have experience of working with patients with late onset Pompe disease. Prior to working at Cardiff University, I was at Queen Square in London, which is the National Centre for the Treatment of Patients with Pompe disease. And as a physio, I helped to develop the service there for supporting patients in terms of assessment and the management of their symptoms through exercise. And at this point, I think it's important to define what I mean by exercise, because everybody will have different understanding of what exercise means to them. So over the course of the presentation, I'll be discussing exercise in terms of physical strategies that you can use to help manage your symptoms. That might be aerobic training in the form of cycling, walking. It might be strengthening using light resistance weights or bands to help maintain or develop strength. Maybe stretching, postural management, as well as respiratory devices as well. So that's what we're going to define as exercise just from the offset, okay? So when it comes to engaging patients with exercise, these are the well-established barriers that I know everybody in this room is very familiar with. And your physio, my job as a physio, is to help patients overcome these barriers, to find strategies to help reduce their impact upon you, and to help patients to engage in physical activity that will reduce the impact of fatigue on their day-to-day life. And of course, as we all know, with less fatigue and more energy, you are more inclined to do things like exercise, to be more physically active. And we see this cycle, and it can either have a negative effect or a positive effect. And I see physio as having an important role in helping turn this negative cycle, where one factor has a detrimental effect on the other, into a positive cycle, whereby exercise can help you to be more active, reduce your feelings of shortness of breath, help modify any pain that you may be experiencing, and give you more energy, more vitality. So let's have a look at then the patterns of weakness. Now this is the point at which we need to think about individualizing the assessment to find out which specific muscles are giving you the most cause for concern, which muscle groups are limiting your ability to do the things that you want to do. And your physio can help you with that through a specific assessment of the muscle groups which we know are commonly affected in Pompe disease. Those muscles around the limb girdle and as well as the spine and the diaphragm. So a targeted, individualized assessment of your muscle strength is the first stage of establishing an exercise program. But this is the point also where I need to highlight that I've worked with a range of patients with different neurological conditions, and one of the things that is unique about Pompe disease is that the pattern of weakness is predictable. So your physio, if they're familiar with Pompe disease, should be able to target those muscle groups that they know will be affected as the disease progresses. And that has two big benefits. First of which, if the muscle group is already experiencing weakness, then exercise may help to either maintain that or improve it. But if you have muscle groups that are strong at the time of assessment, that will eventually be implicated by the disease process, then that's an opportunity also to increase the strength of those muscles whilst they're relatively healthy. And so a good exercise program needs to be balanced, not just addressing areas of greatest weakness, but also maximizing areas of the body that are relatively strong. A balanced exercise, as I've said there. Your physio also needs to not just think about strength in its individual context, muscle group by muscle group, but also how that strength contributes to overall function. And this is where your physio is, this is one of the unique aspects of being a physiotherapist. It's not about just assessment of your individual physical capabilities. It's about bringing all that together holistically to see how we can improve your day-to-day function, how we can help you to do the things that matter to you more independently or for a longer period of time. So your physio, they should be looking at strength, yes, but also how that strength contributes to functional movements. So this is the point we need to think about now. At what point is muscle tissue beyond the help of exercise? And we accept that as the disease progresses towards the later stages here of disease progression, then muscle tissue, such as is illustrated here, we're not looking at that stage as physios to help improve strength there. But some of the options we have at that stage are around maintaining muscle length so that stiffness doesn't become one of your limiting factors. But if we can get muscle tissue in these earlier stages, around here, then these muscles will be able to benefit from a tailored, individualized exercise program. So what might that program look like? Well, we've used evidence from across a range of different neurological conditions, but fairly recently, the research has started to focus specifically on Pompe disease and tailored, designed exercises for that unique patient group. And these are some of the things that they've done. So 3 times a week is the recommended amount of times for you to be exercising in order to gain the greatest amount of benefit. That element of supervision, you'll see this crop up time and time again in the recommendations, and I'll return to that and talk about it in more detail. But that is a key component when exercising, is supervision. And it doesn't always have to be supervised by a physio. I'll get to that a little bit later on. Having programs that are community-based is going to be an important factor in maintaining engagement with the program. And you can see here, moderate amounts, so not working at high intensities. Very often when you speak to patients as a physio about exercise, if they're not familiar or haven't exercised in the past, then very often they can be put off by the idea that it's going to be extremely intense, involve lifting very heavy weights, that you'll feel extremely tired as a consequence of doing it, and your muscles will ache for days afterwards. Those are usually some of the concerns that patients have. But you can see here the evidence is suggesting a moderate level of intensity. These are some of the exercises that were included in this particular study. But what I would say is there's no one-size-fits-all approach to how to prescribe exercises. And that goes for anybody, whether they have Pompe disease or a sprained ankle. The approach your physio should take should be tailored to your individual needs and how you present on assessment. Also, the exercises were focused on trunk strength, which we know is a major limiting factor. The trunk is an important area of muscle in helping maintain posture, helping maintain mobility, as well as your independence with activities of daily living, getting out of a chair, washing and dressing yourself independently. So some of the outcomes they looked at here were around safety, endurance, so your ability to walk a certain distance, muscle strength, as well as the core stability, which are the exercises I've just shown you. So how long patients were able to maintain those positions for. And you can see here in the results, well, safety wasn't, there was no negative effect upon safety. Okay? Patients did experience some muscle discomfort. That's perfectly normal for any group of people, whether they have Pompe disease or they be healthy individuals. If you suddenly start going to the gym multiple times a week, following a structured program, you will experience some muscle soreness. And that's a big part of the training and education that we deliver to patients. is to help them to understand that this is a normal experience and to not be put off by that. You can see here as well some of the big improvements that were made in terms of how easy it was for people to breathe, essentially how much oxygen they could get into their system at any given time, how far they could walk, okay, over the 6-minute walk. I'm sure you're all familiar with that particular test, 6-minute walk test. You can see that after the exercise, the 6-minute walk test distance improved significantly. And we think then about, well, what does that mean? My 6-minute walk test has improved and my ventilatory threshold has improved. But what does that actually mean to me as an individual? Well, some of the benefits you're going to then experience is that feeling of being more energized, having more energy to do the things that matter to you, okay? That's going to have a knock-on effect on your perceived quality of life. If you're able to feel more independent, more energized, you're able to take a more active role in the things that are important to you, that's going to have real beneficial effects on your quality of life and your mental health and your well-being. Specifically, when you look at the exercises they did, they targeted this long list here of muscle groups. But if we think about the ones that are most important to most people in terms of day-to-day function, then you have the muscles which bring your arm up to the side, important in anything you want to do, whether that be doing your hair, washing your hair, reaching up for objects in and around the kitchen. Those are important muscle groups to help you maintain independence. And you can see a significant increase in strength of those groups as a consequence of exercise. Similarly, your hip flexors, so these are the muscle groups that lift your leg up in order for you to walk and to take long strides, to walk fast, to avoid falling over. And again, those are the muscle groups, so very functional muscle groups that have noticed an improvement as a consequence of this structured approach. And the key thing to highlight here is the level of compliance was very high. And that's a consequence of the supervision. If the physio's turning up to see you in your home, then you're going to undertake some form of exercise, okay? How you manage that in the long term is an important conversation which we'll get to towards the end of the presentation. But that level of support, I need to emphasize, doesn't have to come from a physio. Once you've been set up with the program, you've been taught how to do it, the support can then come from family members, personal trainers, friends or peers within your own group, if you choose to exercise as a group. That support doesn't have to be medical-led, all right? And if you're going to sustain the program, then I think it's important that you take ownership of those exercises, because ultimately they are your exercises. The exercise diaries are another nice way to help you monitor the progression. How many of the different exercises are you able to do? Are there any adverse symptoms that you experience as a consequence of doing them? Those are the important things to feed back to your physio when you next see them. And interestingly, with this study, they've returned to this group of patients 10 years later, and they had a look at whether they are still doing the exercises, okay? So this is very relevant to exactly what I've been saying, okay? So compliance was very high at the time, but how was compliance affected when physiotherapy took a step back? You can see a lot of patients here continued after the training program. So they continued 3 times a week to exercise following that same structured approach, okay? But we also understand that for those patients here and here who eventually stopped exercising, the main reasons for them doing so related to the fact it was time-consuming, it was hard, and the lack of professional support. So these are things that we accept and we understand, and our role as physios is to help overcome these barriers here. Why is it the patients are struggling to fit it in to their busy lifestyles? How can we adapt the approach to make it more manageable? Why are patients finding it so strenuous? Is there a way we can restructure it around individuals' roles and responsibilities to make it more manageable over the long term? And is there a better way of providing this support, some of which I've just spoke about? And we know as well that fatigue is a massive issue in Pompe disease, and how patients experience that fatigue is very much dependent upon you as an individual. But you can see here the figures illustrating how prevalent fatigue is amongst the patient group. And some of these descriptions here are, I'm sure, things that you will very much relate to, about how fatigue affects things like your motivation, how fatigue responds to exercise, and how it then interferes your ability to do your day-to-day tasks. So we understand that fatigue has a significant effect on all of those areas there I've listed, but it's also something that responds very positively to exercise. So in terms of helping you manage your fatigue to enable you to do more exercise and to ultimately enable you to be more independent, there's an important role here for physio in setting realistic goals for you, managing your expectations and helping you balance your exercise program alongside your other roles and responsibilities. Pacing is important as well. Being able to pace your activities and not feeling as though exercise should be done at 100 miles an hour at full intensity, and unless you're sweating and exhausted, then that doesn't constitute exercise. We need to move away from those definitions, because it certainly isn't what the evidence recommends, and neither is it a way for you to continue to engage with those activities. And the advice and education is something that underpins everything we do as physios, okay? Trying to bring people in, a network of people around you to support you in maintaining this. So what are some of the things that are key takeaway messages for you then to think about when considering how to structure and maintain an exercise program? These are sort of the key points that you may wish to consider. Doesn't have to be at that high intensity. I hope that message is sort of clearly understood. Sub-maximal levels are what we would recommend, what the evidence recommends. But again, what does that mean to you? Sub-maximal as a patient is very difficult for you to interpret because it means something different to every individual. This Borg scale is a nice, simple way in which you can help understand what intensity would be classed as sub-maximal. So you could just look this up on Google, you could ask your physio to talk you through it. It's a very simple scale which clearly describes how you should be feeling at different levels of exertion. And you can see here, point 13 on the scale represents 65%, which is what we would class as sub-maximal. So at this level, you should be feeling like you are exercising somewhat hard. You should be feeling tired, but you can continue with the exercise. You should be able to talk in complete sentences. You should feel a little out of breath, but that symptom, that sensation reduces if you take a short break. And that's another important principle, is the breaks. Schedule your breaks regular and often. Okay, so that you allow yourself the opportunity to recover. Excuse me. If you are able to be referred to physio, then the program should be individualized to your own unique presentation. Those muscle groups which are both weak and would need to be improved in order for you to achieve your goals, but also those muscles that you rely upon. Things like your tricep muscles, which help extend your arm. Many patients rely upon those muscles in order to get up from a chair, to get out of bed, to get up the stairs and hold the banister. These muscles, which are your pushing muscles, as well as those on the side of your trunk here, those muscle groups are large muscle groups that are relatively unaffected by the disease in the early stages. If you can strengthen those groups early on, then you can help utilize their strength later on when other muscle groups are more affected. You need to adapt the exercise plan to the individual's goals. So if you're going to adhere to an exercise program, and this is the same for healthy individuals also, it needs to be motivational. It needs to be something that the individual wants to get out of it, okay? So having the exercises very much orientated towards a final goal is very important. And you as a patient should understand why you are doing an exercise. The relevance of it should be important to you. And they should be targeted at specific muscle groups. You can see here that most commonly perceived barriers to exercises across patients with various neuromuscular diseases. This research is from patients with a variety of neuromuscular conditions. But you can see the most commonly perceived barriers are around lack of energy, lack of motivation. Exercise can help with those things, particularly if you're being supervised, then the lack of motivation can be overcome. Exercise is boring and monotonous. That's where your physio needs to review your program. It should be progressive. It should change in accordance to how your disease changes, how your symptoms change. The exercises should be adaptable. The support and education is very important, particularly around continuing with that exercise program over the course of the disease and allowing sufficient rest periods. So this would be the recommendation around frequency, 3 times a week, and try and alternate the days in which you exercise so that you give yourself a full rest day in between, okay? These are some of the modalities I've commonly used with patients. Balance is obviously something that is severely affected in Pompe disease, particularly as we get trunk weakness. Your ability to remain stable can often be compromised. So these balance activities are very important here, and they can be integrated into your day-to-day routine in and around the kitchen, whether you're waiting for the kettle to boil, you're waiting for food to prepare. These are the types of exercises you can do for a very short period that just help you maintain your balance and give you that sense of confidence when walking either inside your own home or out in the local community. If you're struggling with standing for a balance activity, then these balls are very good, these Swiss balls, to sit on. And again, you're able to engage your trunk muscles here to help you remain stable whilst sat on the ball, which wobbles around in accordance to how you move, okay? But that is a nice modality if standing up is either tiring or you're unable to stand up. The TheraBands that we often prescribe as physios are a nice way to help patients engage in more resistance-based activity. And the bands can come in various resistance levels, starting off very simple to more heavy resistance bands. And again, you should be doing things here that are targeted to those muscle groups that are most affected, as well as the ones that contribute to your day-to-day function. Hydrotherapy was a modality that I used to use quite a lot. This can often be challenging for some patients if they have particular diaphragmatic weakness or they struggle to expand their rib cage against the pressure of the water. Some patients find that the pressure of the water is too difficult in terms of helping them to breathe, okay? But if your respiratory system is relatively unaffected in Pompe disease, then it may be that the water is helping you achieve full ranges of motion then, okay? And some patients really enjoy working in the water because your sense of stability is also relatively unaffected. If you fall over in the pool, it has less effect on you than if you fall outside. And then in terms of doing aerobic activity, these recumbent bikes are very helpful, particularly because they don't have a large bar in the middle for patients to try and step over. You can just go in and sit down on them, and then you have the seat, obviously, that is well supported in and around your trunk. So focusing now on the respiratory management, the evidence here is not as strong as it is in exercise, which I've just shown you, but there are some studies that have looked at training up expiratory muscles, so those muscles that help you breathe out and those muscles which help produce a cough, which can be particularly important if you do have a buildup of secretions in your respiratory system. And what they've looked at is how they can work with resistance devices, so devices that make breathing in that little bit more difficult. And the idea then is the same principle as using bands as resistance. You are essentially forcing the muscles to work harder in order to inhale the oxygen. So there's been some studies looking at this, and what they found here, if you look at here, is there's very often it isn't one of the reasons as to why people are referred to physiotherapy is for the management of these respiratory issues. So very often you'll find that patients are referred for physical issues, but as physios we are trained, we've got excellent experience in managing patients with respiratory issues also. So this is something your physiotherapist should be able to give you advice on and help you with. So yes, in terms of helping you maintain function, but also clearing your techniques as well. So giving you advice on how best to clear secretions from your system, helping you to breathe more efficiently. And this was the device I was just talking about. So this is a device that is designed for you to sort of, you put this bit here in your mouth, and then you can resist, you can alter the level of resistance using this chamber here. And then what you are going to have to do is do lots of repetitions, around 25 repetitions of this in order to gain a benefit. So from my point of view, working with patients who've got Pompe disease, thinking about what I see as the role of the physio and what you should be asking your physio to support with includes advice and education on pacing and managing fatigue, thinking about how you can optimize and preserve your muscle function, different ways in which you can help with airway clearance and trying out the training aid for the respiratory muscles, and then thinking about minimizing, preventing secondary complications. Okay, well, thank you very much for your attention, and if you have any questions, please feel free to ask.
Vamos muy mal de tiempo, entonces.
We are very late.
Okay, go for it.
No, yo quería ser policía.
Okay, I'm the bad cop. I'm giving you the bad news. We are very late. So if you have questions, doubts, comments, please send those things to me, and I will refer that to other speakers. But I'd like to say, it's important that you're here today. In the association, in Pompe Patients Association, we always struggling. We say to the patients, you cannot make exercise with a healthy person. You spoke about the scale. The muscle doesn't need to be exercised at more than 70%. Don't do the exercises with a healthy person, because sometimes we do too much. You are punishing your muscles. You are exerting too much. This is on the streaming video. Please read it, watch the video. Don't exert too much. The respiratory exercises is very important. I have the device, and I think it's very important to use those devices, to go to your physios. Physiotherapy is fundamental for your disease. Thank you.
Thank you.
Retos y futuro en la...
Challenges and future in Pompe disease. The open door to hope is given us by research and experience. The daily treatments with the different medical specialties, with the studies, with the challenges. What are the future challenges for Pompe disease patients? This is the question for the second round table, facilitated by Dr. Adolfo López de Munay from the University Hospital of San Sebastian.
Con la participación
With the participation of Dr. Jordi Díaz from Newcastle Research Center, Dr. Cristina Domínguez Hospital in 12 de octubre in Madrid, and Verónica Jiménez Center for Animal Biotechnology and Gene Therapy in the University of Barcelona. Welcome.
Buenas tardes, muchas gracias.
Thank you very much to the association for inviting me to this roundtable, which is the end of this session today. We're talking about the future, and we have here today 3 speakers coming from various backgrounds, and they will tackle many aspects relating to the future. Pompe disease is a long journey since the beginning of the disease description. But in the last 20 years, when research has brought changes, real spectacular changes have come up, and this has changed the natural history of a terrible disease. But we want to go beyond, and this round table is dedicated to all those aspects that are concerning us, that are worrying us, and that give us work. So we will have 3 talks, and I would like to ask you to be brief in order to have time for questions afterwards. So please, Jordi, it's your turn.
Gracias, Adolfo. Bueno, en primer lugar,
First of all, I'd like to thank once again the association to having invited me. It's been 12 consecutive years since I started to take part in your meetings. So I see Ivan and I see other children who are now grown-ups. It's a pleasure to see you year after year. I'm going to start with gene therapy, because we've been discussing about this for many years. This is a slide that I already showed you. What are the therapeutic options in Pompe disease? What we see is that you have different options. Cristina will speak about new enzymatic techniques that are already approved, and I will speak about other therapeutic options. Gene therapy, is the measurement of GAA, etc., and other treatments. And this panel, this figure, shows the strategic side to it. What can we do with all these therapies? I'm not going to speak about enzymatic therapy because it's already here, because you will have it in hospitals, you will start treatment with these new drugs, but I'm going to concentrate on gene therapies that are now being developed. In other meetings, I know about this, but there are new people. What is gene therapy? Provides a copy of the missing gene. This allows our cells to express a protein, again, that in theory is a deficit protein in our body, and this leads to improving our situation. There are basic components. The healthy copy of the gene that is missing in our body, what we call the transgene, then the promoter, this gene will express thanks to it, and the viral vector, which is the truck, taking the gene to all the cells in the body. Basically, we use viral vectors, that is viruses that work fine because they infect our cells. And what we want is to infect the cells and then bring them these vectors and this virus. This is the clinical trial, the transgene. It has a copy of the GAA, and then here the promoter and the truck, and then we're going to pack this in the truck. All of this will be packed into the truck for transportation, and these are the vans that we're going to use to transport these genes to our cells. So we have different options. We can use viruses, and we have another option that are being under research, using nanoparticles, lipidic components inside. They can hold different drugs, protein, or RNAs or DNAs, and this is being researched. And there are many types of vans. Here we will speak only about viruses, but that there are other possibilities. We have many viruses. They have been tested for gene therapy, but basically those who are most used in clinical trials are associated adenovirus. We've been speaking about lentivirals, and people are working lentivirus in Spain. But if you see what the studies say, all the clinical trials use adenovirus. Why? Why adenovirus? Because they have a great infective capacity. They get to many different cells in our tissues. This is one of the main challenges in gene therapy, because we need to know if the distribution is enough. The skeletal muscle is the most abundant tissue in the body. If you are 70 kilos, muscle is 30 kilos. It's full of muscle fibers with a lot of nucleus. They need to receive a copy of the gen, millions of cells, and they need the virus. So it's like trying to deliver a package in a small village, having just one van. But if go to a big city with one van, you cannot deliver the same package in Barcelona. It's easier in a small village. The first challenge, we need to get to all those cells with many vans. So we inject millions of viral particles. In gene therapy, patients receive 6 by 10, 14 viral particles, trillions of viral particles, which are going to enter the body of the patient in half an hour. Distribution is affected by our circulatory system. When I am injected in my vein, first it goes through the liver and it filters our blood. It's a fundamental function of the liver. So these entering virus are being retained in the liver up to 70%. They're stopped there. And we are losing our vans, and we are losing a great amount of vans being stopped by the liver. One of the main problems that we have. Adenovirus don't go to the muscles. They go to all our cells, to the muscles, to the pancreas, to intestine, lungs, kidneys. At the end of the day, those who get to the muscle are just a reduced number of vans. For this reason, we try to take the adenovirus that have a specific tropism for muscles. They like muscle. There's not just one adenovirus, there are many adenovirus. Each one has a number. And most of the trials with muscles use adenovirus 8 because this has a very high capacity of getting to the muscle. There's a special tropism for the skeletal muscle and the cardiac muscle, but also for the liver. And that is the great advantages of this adenovirus. There are many clinical trials to try and improve tropism of this adenovirus so that many packages of adenovirus get to our muscles. The MyoAAV, these are specific adenovirus. This has been tested on mice, and they demonstrate a higher capacity to reach the muscle. We spoke about the promoter. Very important. Our vans are going to get everywhere in our body, to the liver, pancreas, intestine. But we want our gene to be produced only in the muscle. That's where we need it. That's why we will introduce a promoter, which is a specific molecule. It is called the creatine kinase promoter. The educational material of pharmaceutical companies show this figure to us. That's why we have a muscle creatine kinase promoter. It's the expression of your protein will not go to an organ where you don't need it, but it will express in the muscle. That's where you need it. And then Hannerieke said that viruses do not integrate in the gene material, but this is an associated problem. It's good that they do not get integrated because this reduces the risk of mutagenesis. When a gene is integrated, basically, there's a based and it's cutting and paste. It takes a random chromosome being cut, and then it pastes our DNA. And every time the cell divides, the gene remains there. This happens, there's a risk, because I will cut and paste in the incorrect place. That's mutagenesis. With adenovirus, this doesn't happen. Our DNA will stay here as an episome, but this has a drawback. When the cell is divided, this episome is lost. It doesn't cross and it doesn't get to the daughter cells. When there is a high level of proliferation of cells in your tissue, this strategy is not useful. Muscles are tissues where there's little proliferation, but with patients, there's a certain degree of cell renewal, a certain degree of proliferation, and that's what we call the dilutional effect. In time, the number of copies that your muscle receives may be reduced. My question is, how much time can we expect that this gene expresses? Is that for everyone the same, 10 years, 5 years? What is the longer time we can expect the gene to be expressed in our body? We don't really know. There are some trials and studies in monkeys, and they say it would be like 10 years in humans, but we don't have real answers. Amongst the other challenges, what are the secondary effects of the treatment? I call them like inflammatory effects related with infusion of the virus, immunomediated effects produced by the presence of a new protein, a protein that your body has never seen, and then the antibody production. I'll start with this last element. Antibodies are our defense weapons. Half of the people here have had a flu or diarrhea caused by adenovirus, but we have created defense antibodies. When the adenovirus comes back again, our body will recognize it and we will fight against it. But for people who need gene therapy, antibodies are a problem. If you have an antibody against the adenovirus, when you receive your treatment, the adenovirus die and there's no effect whatsoever. But if you receive the first infusion with the treatment, you're going to generate antibodies. It's normal because you receive millions of adenovirus. And if you need to go back and have a second treatment, this is not possible because you have antibodies in your body. So there are many studies trying to give immunosuppressors during and after the gene therapy to reduce that antibodies response. You will produce very little antibodies. And for those who have antibodies, I will give you immunosuppressors to reduce the effect of antibodies.
Another major aspect is the inflammation, and I think that here we can have a certain number of affections, which is the immediate inflammation during the infusion of the virus, with fever, with a certain degree of rash on the skin, but also we can have also other parts of the body, organs like the liver that is going to get inflamed, and also we can kidneys affected, or the muscles, or the bone marrow, and then the patient could develop quite severe conditions. But of course we have treatments for that. But there is also a new concept which is closely linked to these inflammatory responses, which is the concept of empty capsid. 6 years ago, what we did is to mix the virus capsid with the DNA, and we had it mixed, and higher is the number of capsid to have the DNA inside, but it's not 100%. You are not really reaching the number you need. But if we have a greater number of empty containers that haven't been transported with this disease, this is closely related with the side effects in patients. For example, the bodies regulates this, and they have a certain 70% as a threshold. This is the number of virus that has the gene in order to low down this drawback. But in Pompe, we have two kinds of strategies. The one that takes the virus to the heart and the muscles, that is a phase stage 1 of these tests, which is Estelas, and there's a second strategy that wants to use the liver as a target. The liver is getting the greater part of the virus, and so we do not need those higher doses. But the advantage is that we have an enzyme that is produced and is distributed through the blood current. And I cannot present you the results of this clinical test because we haven't published them, but we have had 2 pharmaceutical that have done a certain number of tests. These tests have been stopped because the results are poor. So they're just trying to see what has happened. So this is going to be stopped by the time being. But we also have the ones that are going to receive the treatment. What is the experience of a patient in a trial? When they come, they have first a screening test. We have a physical test and also a detection of the antibodies. If these tests are positive, the patient is not going to take part in trials. If they're negatives, they're going to be part of the trial. The first visit, consultation, a muscular biopsy, and blood analysis, and imagery. And also the treatment is corticoids during 24, 28 hours. And the infusion is in hospitals and in a bed, hospital bed or day care. And the first trials, the patient slept 2 days, but now the patient goes to the hotel or his home, but there is going to be a follow-up during the first week. And then during the 2 first months, there is the weekly follow-up and a progressive reduction of the corticoids. And from 2 months onwards, if there is no liver inflammation or no drawback, the patient is going to have a visit 3 or 6 months with functional tests. We do not know how to confirm that the protein is still expressing itself. We haven't got a 10 years plan or 5 years plan to see if the protein is still there, if we're going to use a scan. We know that sometimes the patient is going to get worse. What is my experience? I have been participating in those 2 surveys. We have talked with the patient. We're going to treat a 3rd patient. In the 3 cases we talked with the patient, and we explain the patient what is the trial about. We also give importance to the expectations. Of course, has to be a team that is fully trained and experienced in gene therapy with medication ready. They will have to produce these drugs, and they will have all the drugs if needed. And it is important to have a multidisciplinary team aware of the secondary effects, the side effects. If there is the liver is concerned, they should be a specialist, because I'm not a specialist in that. So the long-term expectations are important, and it is not the same to have a gene therapy, a patient of 18 years old that has not muscular impairment, and dealing with a patient that has a change in musculature. When there is a scan done, we can see the muscles that have been lost in the way. So think that the gene therapy can recuperate this muscle is not realistic. You won't be able to walk if you are in a wheelchair. But we can talk about curbing the disease. And then we will see if the muscle can regenerate. And we have been talking about the need of having combining the gene therapy with the enzymatic therapy. That is something that is on the table. And there is also a major challenge, which is an industrial and social challenge. Do we have the capacity to produce? We have to know if we are able to pay those treatments, because they are very expensive 2,000 euros for a single infusion. Can we take in charge? And then also we have been talking about gene therapy, but there is another drug on trial that tries to reduce the production of glucogen. This is the glucosynthase. We accumulate glucogen in the pompe. There is two enzymes that produce it, the 1 and the 2. The one that is present in the muscle and the liver, and the second one only in the liver. So we have drugs. There is a pharmaceutical company that hasn't got the patent, but it's called Maze Therapeutics, that have had medication to block this glucogen. So it shows in mice and in cells that when it was combined with the enzymatic therapy, the fourth bar, they reduced considerably the presence of glucogen in the muscles of the mice. So they carried out safety trials with knockout mice and healthy mice, and they were starting phase 2 trial in patients with Pompe, but there was a financial issue. They were going to be bought by Sanofi. Sanofi was going to carry out this trial, but due to the state's situation, they blocked, and so it has been bought by a Japanese company. We do not know if this drug is going to be tested further. I hope that we will very soon know if it's going to be tested. So we have been talking about the blood barrier. This is a study I presented last year, and Sanofi developed antibody that were able to mix the transferrin, and this enzymatic therapy could be combined, and they were going to acknowledge the transferrin, and it was going to cross the blood barrier. So they had studies in mice. So the treatments using this antibody, anti-transferrin, and the enzyme reduced the pink color in the cells. This is a non-treated mice, so you can see the cell without this pink thing, which is the glucogen. So this is the studies carried out with myozyme and with the new drug, and we can see the reduction of the glucogen. And also they were aware of the fact that there was a less brain impairment or degeneration. There was a greater muscular function in mice. This therapy is not subject of the study. For the study, Sanofi is not carrying out the trials. It is stopped for the time being. So as a conclusion, so the new therapies, the gene therapies is tested. We have had problems in other diseases with the liver, but we all have multiple challenges that have no answer, and we have other therapies that are underway. Thank you for your attention. This is my team.
Muchas gracias, Jordi. Bueno, nos lo dejan muy bien para...
Thank you, Jordi. We go on to the second part, which is related to the trials. And when we start research, when we talk about the diseases and the first attempts to improve this disease, there is a jump, which is to go from this academic research to the trials, and it has been mentioned by Jordi. We have to have the funds to do that, and a major aspect is how to do the trials to have as fast as possible the results, to know if we are on a good track. So we have Cristina Dominguez from the hospital 12 de Octubre of Madrid. Yours is the floor.
Buenos días a todos. Muchas gracias por...
Good morning. Thanks once again for inviting me to this annual Congress. these panel sessions that address the challenges and future of the Pompe disease. I wanted to talk about the design of the clinical trials. It is a major challenge to identify new therapies, but it is even more difficult to show that these new therapies are efficient, and we have to do that in time to get those therapies to the patients. So what are the major challenges we face, or the researchers face, when doing those trials? Because this is going to help us to better interpret the results, the clinical results. So these are the objective of this presentation. We will see what are the major barriers, how it's going to show that the new treatment is good and has its advantages, and how all these decisions are going to have an impact when we see the results of these trials, and we will have to interpret them. We will have to apprehend the design and know all the details of these trials, and then after I will be talking about the future of the clinical trials in Pompe disease and how they should be designed in the future. From the month of March, we have two new therapies. The second generation of enzymatic therapies, and both therapies, when we carried out the pre-trial study before the research and in patients, they were able to show in both cases that both in vitro or when looking at the capacity of this treatment to degrade the glucogen in the animal model, it was higher, greater than the previous treatment, myozyme. So before doing this in patients, it was higher than myozyme to degrade all the glucogen. But nevertheless, when we got to the clinical trials, these clinical trials are very different, radically different. The design is different, but what they have in common is that in both cases, the final result, when we look at the patients that wanted to look at the patients' populations and using the results measure that were chosen during the first weeks of this clinical trial, the final result is that they are not able to show mathematically that these drugs are better than the treatment, than the myosin. In both cases, the ones who received the new therapy were feeling better at the end of the trial than the ones that took myozyme. But the advantage of those new therapies were not really shown. Maybe they improved because of the mere it was random, but it should be over 5%. This is what we establish in the clinical trials to see if they are working or not. So does this mean that these new therapies are not better than the myosin? These two treatments are better, I think, than the previous one, than the first one, but it is difficult in a clinical trial to show the superiority. And this is a rare disease, and it is slow evolution. So we face those obstacles. How can I design my trial to really show that the new treatment is better than the old one? So these are the major obstacles these kind of disease face. I will talk about the LOPT, the low incidence, and just to find a suitable number of patients, because if we have no many patients, we won't really see what is the impact of this therapy. And moreover, if we do not know what is the evolution of the patient, and also the clinical manifestations are different, so this is going to make our work even more difficult. And when the disease is already started and a part of the symptoms is due to the fact that the tissue is has been degenerated, a lot of these symptoms are not cannot be recovered. The drug maybe is functioning when we cannot really improve the condition of the patient. These are the major questions we face as researchers when designing a test, a trial. What is the target? First of all, they have to find or to see if they want to have a group of patients that are similar, or do they want to have all the patients in the same set, or he has to decide if this treatment is working or not, and to see what is the major variable they're going to use to measure the result, and what is the time or the follow-up. He's going to design a statistic from the beginning. This statistic scheme has to be pre-designed. These are the decisions that he has to take that will have a major impact when we interpret the results of the trials. What are what is the target? In a rare disease, you think, if I want to show that this medication is working okay, I will find a group that is similar. They won't have a respiratory failure, or they will have a similar progression, and then I will choose the tool to measure their condition to see whether the treatment is able to reverse this condition. But if you do that, you might encounter yourself with a few patients or few individuals, because when you recruit patients to participate in those trials, the recruitment is very long. And so you have to accept a certain number of heterogeneity in the group of patients you are studying. And when you include this heterogeneity, you will face the first problems. You also have to decide the time of recruitment, and this heterogeneity makes that you know that the Pompe disease, the adult form, is quite variable. They have different conditions, and the progression or the weakness is different from one individual to the other, and we cannot predict what is going to be the evolution of the patient once the diagnosis is done. So we have no marker that is going to help us to identify a group of patients that is more homogeneous. These are the three studies I've found before the myozyme that studied the evolution of the patients with no treatment at all. The functions, the motor functions, is measured in a different way. Here, if you look at the forced vital capacity that is measured in the same way, you can see differences between one studies and the other. There are studies that say that the forced vital capacity is worsened, and others are talking about a decline of 1.6% per year. So in patients with the same diagnosis, the evolution is different. This leads us to what we have talked the Russian roulette of recruitment. If you choose the same patients with the same characteristic, and if you are not able to know what is going to be the evolution, so in one of the groups of the patients you're going to treat, some of the patients or one patient can have different symptoms. So if this group of patients are going to have the treatment A, and this other group the treatment B, and in the group A they can be patients that are evolving, progressing slowly, and the other faster. So this is going to have an impact in the results of a trial, because this is a very small group of patients trial. So in some of the trials is enzymatic therapies, no one enabled us to show that there were better. But if we just retrieved one of the individuals from one of the groups, they carried out again the analysis, and then the trial said that the result was better than the myozyme, and only one individual behaving differently changed totally the final result of the test, the clinical trial. So we will have to get to know all those details and these obstacles if we have to show whether a treatment is good or not. Another difficult decision is that you have to decide from the very beginning what is the major variable that will help you to know if this patient is improving or not. We can study a lot of variables in a clinical trial. The one you're going to choose one as the main one, and according to the results, you will know if this clinical trial is successful. You have to choose one, and if the population is heterogeneous, with this same measure, you have to measure the benefits in all the cases, although the clinical manifestations are different. So this decision is also going to be very important. It's going to be key. So we have to have a measure that is quantifiable, and we also have to measure changes in periods. In a specific period, it could be 1 year, 1 year and a half. It is very costly to prolong these trials, so you only have 1 year and a half, and you will have to find something that could be making the difference in 1 year and a half. So you have to be also it has to be related with the severity of the disease. And currently, we also ask the patient how he feels, his functions, and also if his survival is better. So the trend today has also an impact. The ones in the Pompe, this is the vital force capacity and a test of the 6 minutes walking, but there's also other ways of measuring the muscular function, the also respiratory function is important, and we have many factors. All those measures have their drawbacks and advantages. But of course, if you find a functionality measure, it is the individual muscular force is one thing, but after, what is the functionality of a patient? What can he do? For example, measuring his daily activities before and after, it is a good way to see if it's good for that person. But these scales are not maybe so sensitive to the changes when you measure them during 1 year and a half. For example, on a scale, if a patient can just get on his feet with his own limbs, it is going, or if it takes him 3 seconds, or if he needs 4 minutes, if he can stand up, he has the same score. So this scale is not going to be changing, although the patient might be feeling worse. A change on the scale is a change which is important for the clinics, but it does not mean that the patient is better or stable. And also the time of the trial, the duration of the trial, because you need time to identify those changes, and Pompe disease is a slow progressing disease. So here you can see these are the design of our clinical trials as in the past, but what I wanted to say now is what I consider as the future challenge in the design of the future trials. It is a change of paradigm that is happening for quite a while for degenerative diseases with heterogeneous manifestations, and as it is the case of the adult form of the Pompe disease. It consists not in measuring the consequences of the disease, but using a marker related to the severity of the disease, measuring the activity of the disease. It would be a marker that would show how this patient is evolving, and if this marker is reducing itself, the patient is going to feel better. So this is quite old. It was the track of the accelerated approval, for example, for the AIDS, when they wanted to approve therapies, and when the measure was the number of opportunistic infection, for example, or how the defense of that patient were, and they were going to follow up the patient during many years to see whether this drug was efficient or not, and they had to wait. So they started to analyze the virus load, and if the drug was able to reduce the amount of virus, and this would be good. And they authorized treatments that were able to lower the viral load before seeing if the clinical manifestation improved. This has been done not only with the HIV, but also other pathologies where these kind of markers have been used to authorize drugs using only one marker, and then forcing the promoter to have a long-term follow-up and show that the reduction in the primary marker it reflects an improvement of the patient. What could be in the Pompe disease a marker in the activity of the disease? Although the pathogeny of the disease is not clear at 100% in the adults, but it is closely related with the amount of glycogen that is building up in the muscles. And also it is closely linked with the blocking of autophagy and the accumulation of the material. These are primary markers of the disease activity. We should have a tool to measure it, and it could replace other markers that we're using currently that are markers of the consequences of the disease. That's to say, when there is already a loss of muscle and when there is a respiratory failure or a weakness of the diaphragm that cannot be recovered, as you can see in the scan, although here we're trying to show the advantages of a drug, we cannot recover or recuperate those muscles.
I told you that one of the example of trials where we used this approach, a disease in which it's been used, which is similar to Pompe, is Fabry disease. Lysosomal disease, there's a defect of lysosomal enzyme and a substrate that is building up. The sphingolipid is building up in kidneys, in other organs. In the year 2000, there was a drug being authorized using as a primary means the build-up of this substrate in the kidney. They demonstrated that it cleaned up the glycogen. The drug was authorized on the basis of those results. And then, after 10 years, these patients are much better. They have less clinical manifestations than non-treated patients, so it's possible. And I believe this is a challenge for clinical trials in the future for Pompe's disease. We need to identify and validate an activity biomarker so that we need to know the activity of the disease in order to anticipate clinical irreversible manifestations. Thank you very much. Okay, we need to design clinical trials, but we need to translate the lab results before asking the authorization to regulatory agencies. We need the regulatory preclinical test. And one essential step is to test the therapeutic approach in an animal model, regardless of the species. We can work with Drosophila, the worm, mice, pig, but the model needs to recap the basic data of the disease. One of the problems that we have for many muscle diseases that animal species, even though they have mutations on autologous gene, they have a variant for each of these species. Some of these animals do not recap the disease. They have no manifestations, or it's less severe. So we are very enthusiastic to find new animal models that may help us advance the model and to shorten the time to clinical trials. And now, Verónica Jiménez will speak about a new animal model.
¿El mando? Vale, gracias. Bueno, buenos días a todos.
Hello, everybody. I'm a researcher from the Biotechnology Center in Barcelona University. And we do gene therapy too, but I'm going to speak about animals, not about patients. In this round table, I would like to specify what are the challenges for the future. We need to have animal models that reproduce faithfully the clinic aspects of the patients and the development of more efficient treatments in the future. Before explaining the data that we obtained for the development of a new animal model, a new gene therapy approach, this study was carried out within MyoCure, an European consortium. Unfortunately, rare diseases have less funding from the pharma. That's why there are few treatments, because they consider there's no return on investment because you are rare, and they don't want to develop new drugs. That's why there are different initiatives, governmental initiatives in Spain, in Europe, to replace and to compensate for the absence of efforts on the part of the pharma. And this is an initiative of this consortium. As you can see here, the main goal of MyoCure is the development of an innovative gene therapy platform to cure rare hereditary muscle disorders. That's the mission of MyoCure Consortium in Europe. More specifically, in this consortium, we wanted to develop effective gene therapy for muscle dystrophy of Duchenne, myotubular myopathy linked to chromosome X, and Pompe disease. When the consortium was set up, the idea was to develop gene therapy solutions more efficient for Pompe disease, but especially for adults. During the development of this consortium, this changed, and what I'm going to present now is the efficiency data of a new strategy that was developed for Pompe infantile subtype. How come that, in fact, it was devoted for adults, and now it's for infants? As Adolfo said, when we develop a new therapy strategy for a conventional drug or for an advanced approach, we need to have animal models that faithfully reproduce the clinical symptoms of patients. In these models, we need to demonstrate that the treatment is efficient, and secondly, that it is safe. The regulatory agency does not allow you to assess in a clinical study with humans if we only demonstrate efficiency. We need to demonstrate efficiency and safety. For efficiency, we need clearly animal models that reproduce the clinic. So we have different mice. We have the mouse PD model. It was developed 25 years ago. Very, very popular one. We have in total 6 models. I have a pointer somewhere.
Bueno, es igual. Modelos de rato.
Mouse models. 7 models. No activity. So no GAA activity and massive glycogen storage. Problem of these 7 mouse models. Phenotype is closer to a mild form of a Pompe disease. It's the adult type of Pompe. As you can see here, the late degenerative phenotype is a fact. There's a lack of early mortality, and muscle weakness and cardiac manifestations are less severe than in humans.
Las manifestaciones cardíacas, como
So muscle weakness and cardiac manifestations are less severe than in humans. So these models are for adult Pompe and not for infantile Pompe. In my center, it's called animal biotechnology, not a fancy word, but we create animal models for diseases. In our department, we can develop various models. Within our project, we changed the paradigm. We know that for other muscles disease, for Duchenne, the rat models do reproduce the clinical phenotype of patients, and it's not the case with mice. So we had this technology. With this consortium, we developed a new rat model for Pompe disease because we wanted to see the exacerbated phenotype of this disease. Rat is bigger than mouse. It's a bigger animal. Imagine that a rat is the size of a milk Tetra brick. It's small, but it's quite big for us. When we work in gene therapy, the dose response studies where we determine the doses that has an average efficiency for patients, this is more adequate with a rat than using a mouse, which is, in fact, a smaller animal. This is the structure. I won't elaborate. We modified the coding sequences of GAA. Thanks to this modification, we see that mutant rats, after this modification, didn't present any GAA. We didn't detect a GAA expression nor production of GAA protein in any of the tissues. The, cardiac muscle, liver, skeletal muscle, and the central nervous system wasn't affected in rats. I'm going to focus on the muscle phenotype of the disease, because it's basic for skeletal muscle and cardiac muscle. But this rat has been affected also at the central nervous system, spinal cord and encephalus. So the rat model is not able to produce GAA, so we wanted to characterize the rat in detail. This is the glycogen build-up in various muscles in the diaphragm, and the glycogen accumulation in these pictures here in just the age of 4 weeks, and it was exacerbated in skeletal muscles of these animals. Some histological pictures, you see the repercussion of that. These are muscles of a healthy rat, and here the muscles of a new Pompe model. As you can see, there's a clear change in just the appearance of muscles. This is due to the massive buildup of glycogen inside. We wanted to assess the function, muscle function of these rats. In rats, and in mice, we measure the muscle force, muscle strength. Animals grip to this grid, we pull them, and this device measures the mean strength of these animals. This massive build-up plus the morphological alterations derive a very clear involvement of the muscle strength of these animals. The heart is affected too. I will mention cardiomegaly, which is typical of infantile Pompe. The massive build-up of glycogen in the heart. In pink, the amount of glycogen being accumulated in the heart. You see that there's a lot in Pompe's cardiac muscles. We wanted to assess not only this type of involvement, but the massive build-up of glycogen in the animals, and the body weight was affected. Here you see the significant difference in body weight, because muscles of these animals are lighter. And after all these elements that I mentioned, the percent survival of animals was affected. This is the rodent model with a less survival. Within the 7 mice models, the rat model has a very low survival rate. Therefore, with all the data, in the lab, we thought that we were able to develop a new Pompe model, but for infantile Pompe. It's the only infantile Pompe that exists in the world today. None of the mice models do reproduce the clinical exacerbated effects of an infantile Pompe. So we developed this animal model. Now we have a model. Let's test the new AAV GAA gene therapy with this model. Jordi made a review of all the gene therapy options, so I'm not going to repeat that. I will just emphasize some of the challenges. I had this slide to explain that a vector, the AAV-GAA, is just a virus that we modified in the lab. It has not the possibility to produce infection or disease. We just use the virus as a vehicle, as a vector, to transfer the interesting gene towards the interesting cells. In this case, we change the inside of the virus and we replace it with a fragment of DNA that will produce the GAA protein. Jordi spoke about the promoter. Within this consortium, the virus capsule, the vehicle, the van, transporting the gene towards our cells, it has been modified. Jordi mentioned the types of AAV that exists and natural AAVs. Through gene engineering, we created a new virus that could reach the cardiac muscle in a more efficient way than virus in nature. And we modified this component, which will indicate the amount of GAA protein that is going to be produced in the cells that we will treat. So the cells produced GAA in a great intensity. These are the results. So we treated Pompe rats with a very similar phenotype to infantile Pompe. We treated them very early, 4 weeks of age. And here the weight follow-up. You remember the other slide, you see that rats have a body weight that was very low compared with control rats. With a red line, these are the treated rats. Here we do not see this body weight reduction. So with the treatment at 4 weeks of age, we prevented the weight loss in these animals and the loss of muscle capacity. Here the survival rates in percentages in red. These are treated rats. All the treated rats survived in comparison with Pompe rats which not received the treatment. Amount of GAA activity, red columns, and in white control rats. We see that these rats have more GAA than the healthy rats. They produce more protein than a healthy animal. So the glycogen levels in these rats, in skeletal muscles and in the heart, were totally normal. I wanted to show you a picture because it's more understandable. On the left, healthy rats, Pompe rats in pink. This indicates the glycogen buildup that is accumulated in the muscle cells and the cardiac cells. And here, on the right, these are Pompe rats treated with a new gene therapy, do not present pinkish or fuchsia color. It's clearer because these are healthy cells. Microscope image, it's in the heart of the cell to see the muscle structure, the fibrillar structure. You don't need to understand the structure, but you see the pictures on the left, healthy animals, in the middle, Pompe animals. You see those stains, these circular blobs. This is the accumulation of glycogen. And on the right, the treated rats go back to the same appearance than control rats. This is an image to show the correction of lysosomal distension, because in Pompe disease there's a development of glycogen. So we don't see the red blobs on the right. That means that the treatment has worked. Full recovery of skeletal muscle mass and strength. So the weight of the muscles was recovered, and on the bottom you see mean strength. If we compare red bars and white bars, well, the treated rats are exactly the same as the healthy rats. Pompe rats are in gray, and the levels are lower. So with this new gene therapy, I hope I have convinced you that we reverted the muscle disease and the cardiac disease, but I didn't show you the central nervous system. When this new capside was developed within the European consortia, willing to develop most efficient therapies for 3 diseases, when we developed this capside, the priority was to be able to direct therapy to heart and to the muscle cells, but we didn't take into account the nervous system because we spoke about a virus here. Because this central nervous system is affected. A future challenge for us would be not just to be able to cure muscles and the heart, but to develop a new capside, a new virus, more powerful virus, which will be able to get to the brain and spinal cord, in order to counteract the muscle phenotype and the cardiac phenotype, but also the central nervous system involvement. Thank you very much for your attention. I'd like to thank all the team, all the people involved in Barcelona lab, and to the 3 French groups in Germany, France, and Belgium, members of the consortium where this new animal model was developed, and also the new gene therapy. Thank you very much, Veronica. Just a couple of minutes for questions. I have a question because I want to give the floor also to the audience. Anybody wants to take the floor with a microphone, please?
Ahí hay una pregunta.
Hola.
Hello. All that you told us was really interesting, starting with the last one. The fact that you designed a new virus, can we avoid the problem of antibodies? The antibodies reaction, especially if we need a second infusion? No. As Jordi said, a very relevant problem is the presence of antibodies against this type of virus that we use to develop these gene therapies. Today, if a patient has antibodies, we cannot enroll the patient in a clinical trial. We have AAV therapies for these, and these patients are excluded. But we also work on eliminating antibodies. If they have blood antibodies, we need to eliminate, to remove antibodies. But many people have antibodies. As Jordi said, this type of virus infect us in a natural way. They are all around us. And these infections have no symptoms. We can be infected by this virus and maybe we don't even realize it. So today, it's a very serious problem. It's what the doctor said. Other gene therapies based on other systems, for instance, hematopoietic stem cells modified with lentivirus, could solve this, or another field with nanoparticles. We want to remove the antibodies. We want to neutralize. We need to avoid antibodies. But for those patients who don't have antibodies, they could be treated with this type of gene therapies. But even though they have no antibodies, after the treatment, they will have antibodies. So what happened if we need to infuse a second doses? This virus do not integrate the therapeutic gene in our DNA. They are like floating in the cell, and when the cell divides itself, the modification is not maintained. So they are now intensely researching what is going to happen in the future. We have preclinical trials with monkeys, and we have new approaches that seem to work to prevent the appearance of antibodies once the patients have been treated. We are now researching on this field. But another question to Cristina. In a clinical trial, the markers that you choose are the ones that will demonstrate efficiency. And the problem is that you didn't obtain the expected results. When you're doing the trial, you cannot redirect your research. No, you have to forget about this trial and start from scratch. Once, if you don't finish the trial, you cannot standardize the results because not all patients are treated at the same time. Sometimes there's a difference between patients enrolled in one country and the other. You have to wait for 2 years until you get the results of all patients. And then you realize that it wasn't the best variable to analyze for this particular group. But then you can't do anything. You have to design a trial since the beginning to the end. And then you have to limit yourself to this design because regulatory agencies will not accept a change. For Jordi, the last two treatments you mentioned, one was to paralyze the glycogen build-up. You said that at financial level this has been stopped, but at scientific level it could be an intermediate solution. But it would be easy to access to this. We need to carry out a trial. Yes, new trials. Yes, these drugs haven't been tested in clinical trials in humans. In the reduction of glycogen, well, these drugs have been tested with healthy people, but the other one hasn't been approved for healthy patients to see if there's an effect. So we need more clinical trials for these two new drugs.
Hola.
Hello. Two questions. One for Veronica. Maybe I didn't understood the treatments that you presented. Said that you do not recover what you lost, but now you said that in rats, the rats could recover the strength and the tissue. Can you extrapolate this to humans? No, you don't recover what you lost. We prevent this happening. We prevent the build-up. When the rats were treated, they had already glycogen build-up. But at this age, the muscle acceptance, the functional acceptance was very low. So we need to direct this treatment for infantile Pompe. We need neonatal screening to prevent, not to revert, to prevent that what could happen. With ERT to treat as soon as possible to prevent these signs, this muscle degeneration to appear, to avoid glycogen buildup. We cannot revert. We cannot return to the initial setting. We knew that the rats started to have the phenotype at the beginning, and we treat them very quickly, and we try to stop it. Another question. How can we patients get to know the various clinical trials on the way? In the association, we have certain information, but the neurologist also can give us information. How can we be aware of existing trials so that we don't want to wait too much, because sometimes we're not informed. Well, you have websites where you have information of all clinical trials that are registered. There is an international website and the Spanish Drug Association. You will find information about existing clinical trials in the country. Your association is very important because it can collect all the data. and then share with the members. We as professionals, we are not aware of a clinical trial that started in a center in Spain. The information is there. You need to access it. It's public when it's registered. Your association may have the possibility of sharing that information with you. I can give you information about websites and addresses for that. Microphone, please. When we show a graph and we say this is the sick mouse, and this is the untreated mouse, and this is a treated mouse, it's not the same mouse. These are a group of mice. We do different things with them. Normally, when we study mice after this treatment process, we kill them. There's no pre-test and a post-test. We only make deductions. If we treat early, instead of waiting to see the symptoms, maybe what will happen is what we see in the treated mice, but they're not all the same mice. They don't recover. We demonstrate if we treat early, maybe these symptoms will not appear.
Congratulations for this Congress. It's related with the antibodies and not with the capside. Is where we have the van, the Jordi's van. We just keep this image. We have this van, as Jordi has mentioned. So when we start producing the enzyme, if your body did not have it beforehand, you can react against this enzyme. And that with other pathology, we see that. So yes, I agree with you, fully agree with you. When we published this study, it was one of the questions that we have to show that there is no antibody for the GA. My laboratory is not an expert, but what we told the reviewer is that the therapeutic advantage is seen throughout the life of the animals that are treated. So we can say that they haven't developed those antibodies, and the GA can still go on with its function. And I agree with you, the strategies of gene therapy that are modifying the liver have some advantages, because some are just only modifying the heart, and they are inducing tolerance. And there are studies where we used strategies not with a therapeutic purpose or aim, but to show the concept that if we are able to make the liver to produce this protein, these antibodies are not going to appear. But of course, I have to be cautious. Studies with mice, and the fact of not seeing that with mice is not. We cannot say it's going to be these advantage is going to be kept when we have a mice model. A rat model has nothing to do with what we're doing. We should show it with monkeys, for example, to have a monkey as a model of a Pompe disease is very complex. It is costly. Sadly, we do not have this kind of model of big animals as monkey, for example, where we can appreciate those aspects. I've got a question. What is the maximum time? The microphone is not used. Where we can, in rats, is the whole life of the rat. It was another question that was posed by the reviewer. There are viruses that are not going to be copied. It is also a challenge that has been pointed out by Jordi. In rats, we have seen that throughout the whole life of the rat. In human patients, as Jordi has mentioned, where there is information. There was a hemophilia patient with other kind of conditions. There is no, we have a different situation. This is the interrogation. When this kind of approaches, where we have a modification of the muscles of a heart, or where this is for children, are we going to be able to see an effect in time, or are we going to treat again this patient when we see that the advantage is diminishing? And today, currently, with those models, we cannot extrapolate to human beings. Remark answering to Andrés. There are many things interesting in antibodies in the gene therapy. To start with, the enzyme is in an intracell component. It's not like the dystrophin of Duchenne that is closer to membrane. So the risk of having antibodies with these intracell protein is minor. The results is not really the ones that we have been shown, but they do not show that the antibody production is a problem. So I think it is different when we have a gene therapy for the liver. This molecule has to go to blood, and it's going to be exposed to the virus. And in child therapies, we can have an immune response. The immune response is different in the infantile form because I haven't seen the protein, than in the adult population that has seen this protein, and the screen positive, as has been said by Hannerieke, have seen this enzyme. And these are elements we have to bear in mind in the immune response. If it's an infant or it's adult, if it's through the muscle or the liver. I've got a question for Veronica. One of the major challenges of the animal models in Pompe is that no animal model has autophagia. Well, sorry. You have spoken about an expansion of the lysosome. This does not mean there is no autophagia. This lysosome is accumulated, and the autophagia is defined by the presence of waste that is in the muscle. And it is a major challenge because in human, this is one of the major obstacles of the muscle. We have glycogen accumulated, but the whole system of the lysosomal system is alterated. And visceral autophagic. And second, can you improve the model to be more similar to adults? Yes, we saw it. Yes, of course, we have data that are published. I haven't shown them here because technically it is a bit too technical or too complex for the audience. We have, but in the paper it is stated the autophagia is alterated, the lysosomal myostasis is alterated, and with the treatment we were able to prevent it. But in the second question, you insist on the fact that your therapy is for infantile Pompe, and why not for the adults population of Pompe? It is a therapy that is a gene therapy with an adenovirus that is specific for muscles, and according to the results you have had with mice, it's great. Why can't we have it for adults? Of course, we understand that if you have lost muscle strength, you are not going to recover it, but we have to maintain those muscles. And if this could have an effect on autophagia, yes, of course, it could be also used for adults. But of course, we wanted to approach it from infantile Pompe because we have model. In the labs, we haven't got rat model, mice model, but this could be also valid for adults.
Bueno, pues yo tenía una pregunta en relación.
I've got a question related to the biomarker to see where is a challenge, the relation between finding the biomarker or correlated with the different symptoms of Pompe, or the problem is with the measurement, where lies the challenge with the biomarker. In Pompe disease, in adults, we haven't studied biomarkers that are going to show the activity of the disease, or we haven't got a correlation with the severity of this disease. These biomarkers are not known. We will have to find those biomarkers correlated with the amount of glycogen in the muscles, but markers, according to the autophagic markers, these not exist. About the amount of glycogen, there is a marker that has been studied in the infantile type. It is the 3-saccharide measured in urine, and so there is certain correlation with the amount of glycogen that is built up in the muscle. In children, the common amount of this marker in the urine is related to the severity of the disease, and also it helps us to see if the treatment is working. And in children, this is used, and we have a neonatal screening. And if we add the study of this tetrasaccharide in urine, we can identify the infantile form, and we can separate it from the other. Because the late onset of the disease, this marker, when they are born, it is normal. So we have, of course, some useful biomarker. To use it as a major element, that's not sure. We still have a lot to research in. Sorry. Christina has spoken about that. Christina has said that there is a biomarker called a biomarker, but it's a marker of the image of the muscle that tells us about the consequences of the disease, the loss of muscle. But we could also have other images that would help us to identify the amount of glycogen. Last year, we presented a study where we can measure with an MRI the amount of glycogen. It could be done through a scan. There is no microphone, I'm sorry. He's moving from the microphone. We cannot get the remark. We cannot translate, I'm sorry.
Alguna regla práctica y unido a esto, ¿qué podemos decir de las nuevas versiones del tratamiento mejoradas con respecto al tema de la autofagia, que es un tema importante? ¿Tenemos ahí alguna ventaja suplementaria que nos pudiese, al menos conceptualmente? Hasta donde yo sé no, pero vosotros sois los expertos.
Bueno, no sé. Cristina, ¿quieres empezar?
Cristina? To whom we can advise a change of treatments. I would advise a change of treatment to all the patients that are not stable, and where we can show in the evolution that is worsening. I would advise, maybe all of them, I would say, because those who apparently are stable in the test, you get more tests, you have a scan, and you can see that the evolution of the disease I would like to know where there is a progression in the degeneration of the muscle. In all the cases, while I see that there is a progression, I advise them to change treatment, because I think both treatments are better than myozyme. And to add to that, I wouldn't start with myozyme. I think that Pombility and Opfolda is approved for patients that are older than more than 80 years old, and this cannot be used in a pregnant woman. Or they wish to have a child. So maybe it's not the best treatment. That has to be looked at, because if she's pregnant, she will have to change treatment. I don't think there should be a preference. I think that there are other physicians in the room, they could say, but I think we haven't got to data enough to advise one or other treatment in this group about autophagia. There is no data. I know that Nina Raven studied the models of mice comparing mobility, and they saw that there was certain difference. There was more. I think that these animals are not going to have the same level of autophagy. Animals haven't got that. So the gene therapy show spectacular results in animals, but sadly, they cannot be transferred to human being models, to human beings. There's autophagy is maybe related to other factors. I don't know. It is very difficult. Sorry, but he's not using the microphone.
Planteamos a Sanofi la posibilidad de ver si se podía modificar la autofagia. Da mucho miedo, es una función muy importante, tanto si está sobreexpresada como si está infraexpresada. ¿Hay algún fármaco, diríamos, coadyuvante a la terapia enzimática sustitutiva que esté más o menos cercano?
Bueno, se hizo rapamicina.
Yes, there was rapamycina to inhibit autophagia. You can stop autophagia. There are models in mice where autophagy is blocked or was blocked, and it improved the Pompe disease in these mixed models. But of course, mice who did not have autophagy and those developed another muscular disease. So there is no treatment that is going to stop autophagia. And this process, it is needed in a muscular fiber because it's going to recycle all those elements. If you recycle those proteins, it is important. So this is one of the major questions in the Pompe disease, how to activate this system. For the patients, we have changed the treatment. What has to be the follow-up? So there is a lack of control. My neurologist is here. It will depend upon the patient. Twice a year is optimal. I see my patients in a shorter period because I would like to see any kind of change, but I am seeing them after 3-4 months. But I think twice a year could be enough to carrying out all the tests, and if the patient needs ventilation, it depends. But twice a year, making all the tests, and I think that 2 years, it would be great, twice a year. I have to insist that we have had guides in all those doctors that are attending Pompe. We have some guides. This is quite good, and we advise these consultations, the frequency. Maybe you could tell them that there are some guides for the consultations frequency and the follow-up. Thank you. Thank you. Thank you to the speakers. Thank you for participating, and thank you for your questions. And now I'm going to give the floor to the associations to close this event.
Llegamos al final.
We reached the end of our fourth Congress, intense Congress. We have addressed many topics that are of great interest for the patients, the physicians, and the relatives of the patients. Thank you to the expert doctors, researchers that have attended this event, and we have shed a light on the daily life of those patients. Thank you for your participation once more. We want to keep on working with you in the next edition, so see you soon in the 5th Congress of Pompe. Thank you.
La enfermedad de Pompe es una enfermedad genética provocada por alteraciones en el gen que codifica la proteína alfa-glucosidasa ácida, la única capaz de degradar el glucógeno de los lisosomas. Esta enfermedad presenta dos formas: la enfermedad de Pompe de inicio infantil, que aparece en niños menores de 1 año y con una actividad enzimática menor al 1%, y la enfermedad de Pompe de inicio tardío, que se caracteriza porque la actividad enzimática está entre el 1 y el 30% y no cursa con cardiopatía. A pesar de ser una enfermedad que afecta a todos los tejidos del cuerpo, lo hace especialmente en los músculos, de forma que el glucógeno se almacena inicialmente en los lisosomas, los cuales acaban rompiéndose. Esto hace que el glucógeno, junto con el resto de enzimas lisosomales, se libere al citoplasma de la fibra muscular, lo que provoca una disrupción mecánica y una disfunción lisosomal que, si se agrava, puede llegar a ser irreversible. De forma progresiva, los músculos acumulan vacuolas llenas de glucógeno y material autofágico, haciendo que la fibra muscular vaya perdiendo su función hasta su necrosis y sustitución por tejido graso y conectivo. Esto se va a traducir en una serie de signos y síntomas característicos de la enfermedad de Pompe, que marcarán la evolución de la enfermedad, dando lugar, en ausencia de tratamiento, a una discapacidad permanente. En el caso de la enfermedad de Pompe de inicio infantil, IOPD, los síntomas comienzan a los pocos meses de vida. Los pacientes suelen presentar cardiomegalia, hipotonía, debilidad muscular, dificultad respiratoria, dificultad para alimentarse y retraso del crecimiento. En el caso de la enfermedad de Pompe de inicio tardío, LOPD, las principales manifestaciones clínicas pueden ser una CPK alta, acompañada de síntomas inespecíficos, debilidad muscular proximal, sobre todo debilidad de cinturas, e insuficiencia respiratoria temprana. En cuanto a la hipercecaemia, es importante saber que una CPK normal no descarta una enfermedad de Pompe, aunque es excepcional. Suele estar alterada dentro del rango de 300 y 3000. En ocasiones puede venir acompañada de elevaciones de las aminotransferasas y no suele cursar con rabdomiólisis. Al ser una miopatía, la enfermedad de Pompe de inicio tardío se caracteriza por cursar con una debilidad muscular fundamentalmente axial, en la que destaca la hiperlordosis, y por afectar inicialmente a las extremidades inferiores, estando implicadas sobre todo zonas proximales y compartimentos posteriores. Otros signos posibles son la ptosis palpebral, la escápula alada leve y simétrica y la macroglosia. Además, se conoce el orden de afectación radiológica de los músculos en resonancia magnética en la enfermedad de Pompe, siendo algunos de los primeros afectados la lengua, a pesar de no presentar síntomas precozmente, o los músculos subescapulares. Entre los primeros afectados también se distinguen algunos músculos de los muslos, tales como los aductores, isquiotibiales y cuádriceps, así como los músculos de la pelvis, los paraespinales o los oblicuos abdominales. Para una correcta evaluación de la debilidad muscular es necesario realizar una exploración muscular en la que el músculo explorado esté en posición adecuada y evitando el efecto de la gravedad. realizar una exploración funcional como la maniobra de Gowers, evaluar cómo el paciente salta, sube escaleras o se mantiene a la pata coja, entre otras, y anotarlo en su historial para poder llevar a cabo un seguimiento. Además, hay otras técnicas que se pueden emplear, como la resonancia magnética, que resulta de gran utilidad en el diagnóstico diferencial, la biopsia muscular, que indica patología cuando se observan vacuolas cargadas de material Pas positivo y una fosfatasa ácida alterada, pero que puede ser normal en un 30% de los casos, y el estudio